Hello, and welcome to the Proluent instruction video, where we show you how to use your Proluent pre-filled pen. Before using your pen, read the entire instructions for use found in your Proluent package and watch this video to make yourself familiar with each step. Those instructions, along with this video, provide fully detailed information about each step for treating yourself with Proluent. Use the Proluent pre-filled pen as directed by your healthcare provider. The steps for treating yourself with Proluent are the same for both the 75 mg per milliliter and 150 mg per milliliter dosage strengths, but in this video, we will show you how to use the 75 mg per milliliter pen. You should start with the dose prescribed by your healthcare provider. Proluent is a self-administered injection from the pre-filled pen that you see here. The pen includes a blue cap, a yellow safety cover, an inspection window, and a green button. To prepare, take the pen out of your refrigerator. First, look at the label on the pen, then check to see that you have the correct dose. Green 75 mg per milliliter for this pen, and check the use-by date. Then look at the window and check that the liquid is clear, colorless to pale yellow, and free from particles. Do not use if the window appears to be solid yellow. It is okay if you see an air bubble, but do not use the pen if it has been dropped or damaged. Now, let the pen come to room temperature for 30 to 40 minutes. Do not heat the pen, let it warm up on its own. Also, do not put the pen back in the refrigerator. When you are ready, gather alcohol wipes and cotton balls or gauze pads. Please make sure to have a puncture-resistant container available to put your Proluent pen into once you are finished. Ask your healthcare provider about the proper way to dispose of your used pens. Next, wash your hands with soap and water and dry them well. Then, take your pen and supplies to a comfortable, well-lit room where you feel relaxed. Sitting or standing is okay. Now, choose where you would like to inject Proluent. You can inject Proluent in your thighs, belly, except for the 2-inch area around your navel, or your upper arms. Do not use Proluent on skin that is tender, hard, red, or hot. Do not use the pen in areas where you have visible veins. Try to rotate the injection site each time and do not use the exact same spot as you used for your last injection. Once you have chosen the area where you would like to inject Proluent, wipe it with an alcohol swab and then let dry. Now you are ready to use your pen. Hold the pen in the middle with one hand. With your other hand, pull the blue cap straight off. Do not twist it off. Once you have taken off the cap, do not put it back on. It should be placed in the puncture-resistant container. Also, be careful not to touch the yellow safety cover. Put the pen like this in the palm of your hand in an upright position so that you can clearly see the window. Place the pen straight against your skin at a 90-degree angle and firmly press it into the site until you cannot see the yellow safety cover anymore. The pen won't work if the yellow safety cover is not fully depressed. If needed, pinch the skin to make sure the injection site is firm. Next, you are going to push and immediately release the green button with your thumb. You will hear a click, which lets you know the medicine is being delivered. Keep holding the pen against your skin after releasing the button. The injection may take up to 20 seconds. Watch the window. You will see the yellow marker moving as the medicine is being delivered. When the entire window has turned yellow, the injection is finished. You may also hear a second click. This may take up to 20 seconds. When the window turns completely yellow, you are finished with the injection and can pull the pen away from your skin. Now that you have finished, you may see a little bleeding. Do not worry, just hold the cotton ball or gauze pad over the site until any bleeding stops. Do not rub the area where you have injected Praluent. Be sure that you put the used pen in a puncture-resistant hazard container right after use and keep it out of the reach of children. Follow your local guidelines and ask your healthcare provider for the appropriate way to dispose of the container once it is full. Remember to keep Praluent pen and all medications out of the reach of children. Use the Praluent pen once only and then dispose of it properly. We hope you found this video helpful. It is our goal to help you along every step of your
let me welcome you in this fourth wave of IAVA CaseBox in collaboration with ACC, Dr. Julia Grabsa. We'll start this evening with symposium, industry-supported CME activity. And in this occasion, I would like to thank Sanofi company for their continuous support to the activity of IAVA Society and CaseBox Waves. With me today in the panel in this symposium, Professor Atif Al-Bahari, Vice President of IAVA, and Professor Osama Sanad, Executive Board Member of IAVA Society. Of course, we'll start this symposium by a presentation from our colleague and the Secretary of IAVA Society, Professor Said Farag, Professor of Cardiology, Zagazig University. And of course, I don't need to say that Dr. Said actually put the CaseBox waves on the maps of IAVA activity, and this is it become now one of the main activity of our society, and it is usually interesting and always interesting. So let us start with this presentation about acute coronary syndrome, the hidden time bomb. Dr. Said Farag.
Thank you, Mr. President. Good evening, everybody. Good evening, my dear professors, Professor Atif and Professor Osama. Actually, as Professor Ashraf said, it will be an interesting night, the fourth wave of the CaseBox, with a bunch of fantastic cases and a bunch of experts which will discuss and moderate those cases. Actually, also, I'd like to thank Sanofi company for its sponsorship for this wave, and also to thank ICOM company for organizing this fantastic night. Actually, the topic of today is the acute coronary syndrome. And acute coronary syndrome, when we hear this statement, all of us feel like shivering. Why? Because you know that the acute coronary syndrome is one of the most common cause of death, maybe on the top of the list of the causes of death all over the world. And I'd like to title my presentation today because of its problematic aspects as the hidden time bomb, and we will see how the acute coronary syndrome is the hidden time bomb. As we all know that the ischemic heart disease is the leading cause of death worldwide, and it's representing in 2019, and it is 5 years before, about 9 million deaths. Imagine the number of deaths the acute coronary syndrome can cause nowadays. The ischemic heart disease come on the top of the list, for the responsibility of death was 9 million in 2016. Death rate from cardiovascular disease in selected countries in Africa and the Middle East, and this is actually by the World Health Organization. We can appreciate here the condition in Egypt. It is really considerable that the ischemic heart disease is responsible for the majority of deaths because of its problematic issues. Here I have the privilege to present, maybe it is for the first time, our great work by the IAVA Society, which is the cardiorisk project, the final data, the prevalence of atherosclerosis risk factor in Egyptian patients with acute coronary syndrome, the final data of the nationwide cross-sectional cardiorisk project. It is recently published in the Journal of Public Health of Africa. I'd like here to give you one slide that show you the risk factor profile in the Egyptian patient, which is very important to know that the abdominal obesity representing the majority of the risk factors. Also, we have the obesity, this current smoking, percentage of 48, the type 2 diabetes, the percentage of 38, the dyslipidemia, the percentage of 48, which representing actually one of the major risk factors for acute coronary syndromes in the Egyptian people. And our conclusion in this very interesting registry that among Egyptian patients with acute coronary syndrome, premature presentation is common, 51% of cases with significant higher male preponderance, with abdominal obesity is the most prevalent risk factor. Most traditional risk factors apart from smoking were more prevalent in women than men. There was a very good adherence to evidence-based medical therapy for hospitalized ECS patients with modest gender disparity. Female had similar chances for an early invasive management strategy with coronary angiography compared to the male counterparts. And I think this study will be a platform for years in studying the risk factor profile for those patients developed acute coronary syndrome, and it will help us not only for the collection of data, but also for the tailoring and the planning for the treatment strategy for those very problematic patients. Let's come to our pump. Our pump for today, our case for today is a 59-year-old male cigarette smoker of 1.5 packs a day for 30 years, controlled hypertension, controlled type 2 diabetes mellitus, moderate renal dysfunction with eGFR of 50, recent anthraceptal nestomy 2 months ago, with BCI done for him with second generation drug-eluting stents to the proximal LAD and first OM of the circumflex. Not only this, but also mild heart failure in the first 24 hours, and there is anterior apical and lateral hypokinesis in the echocardiography with estimated left ventricular ejection fraction of 48%. And one of the very important data we can get from this case is his LDL cholesterol is 220 milligram in the first hour of the MI. So as you log to this case, with a cluster of risk factors, with actually atherosclerotic coronary artery disease and acute event presented by acute event 2 months ago, and complicated also by heart failure in the first 24 hours, and unfortunately an LDL cholesterol of 220 in the first hour of the MI. And this will be the key for our case, and please remember this figure. Because of all of these risk factors, and because of the current status of atherosclerotic cardiovascular disease, and because of his LDL in the background of this pump, we can take all the measures to stop this pump from exploding again. What is the patient's cardiovascular risk? As we all know from this famous slide from the European Society of Cardiology Guidelines 2019 for the categorization of the cardiovascular risk, we can here appreciate that this patient, because of the atherosclerotic cardiovascular disease, which is proved by the development of acute coronary syndrome, this patient is at very high risk. And this will help us, this categorization for the risk of patients will, of course, help us in putting the proper strategy for treating these patients, for preventing another attack to occur, which I think if another attack will occur, it will be much more fatal than the previous one. This is a very fantastic slide, and I like it so much. Why? Because it helps us a lot to precisely categorize the patients. And in Europe, they made two charts, one for the low-risk region in Europe and other for the high-risk region for Europe. And they mean by this reclassification that to precisely do the risk categorization of the patients by categorizing also the countries at low risk and high risk. Not only this, but also in some countries have a cardiovascular disease mortality rate more than 350 in 100,000, and the high risk chart may underestimate risk. So if we put the criteria of the high risk chart on some countries, I think we will underestimate the risk, and unfortunately Egypt is one of those countries. And if we have a look here to the guidelines, with a class 1 recommendation that LDL cholesterol is recommended at the primary lipid analysis method for screening, diagnosis, and also management. It is very important to know. If we will back again to our patient, as I said to you that LDL cholesterol is 220 within the first hour of the myocardial infarction, started on rosuvastatin 20 milligram, which is a high intensity statin, plus ezetimibe 10 milligram daily in hospital, and he is kept on this treatment, and on treatment the LDL cholesterol became 110 milligram per deciliter. So it is important here also to remember again this figure, 110 after the use of the rosuvastatin 20 milligram, which is high intensity statin, plus ezetimibe 10 milligram daily. What LDL target would you aim for this patient? If you would like to answer this question precisely, we have to go immediately to the guidelines, because in the secondary prevention, as in our case, at a very high risk, which is also our case, an LDL cholesterol reduction 50% from the baseline, and LDL goal of less than 55 are recommended, which is earlier. If we got 50% or less than 55, we have to get it for class 1 recommendation level of evidence A. Another important data here I'd like to highlight in this slide, that for patients with atherosclerotic cardiovascular disease who experienced a second vascular event within 2 years. And if we have a look to our patients is very susceptible because of high level of risk, because this cluster of risk factors, because of the procedure done for him, I think this patient is very susceptible for the second attack. Here we can look for this recommendation, which is not, of course, applied to our patient, but we have to consider for patients with atherosclerotic cardiovascular disease who experience a second vascular event within 2 years, not necessarily for the same type at first event, while taking maximally tolerated statin-based therapy, and LDL cholesterol now shifted down to be less than 40 may be considered. And I think that this recommendation will be shifted up in the coming guidelines, because in those subsets of patients which can consider them extremely risk patients, we have to keep them the lower as we can. And as by evidence, as I will show you in the coming slides, the 40 milligram, I think, will keep these patients much more safer from getting a second attack, which will be much more fatal. Actually, the American Association of Clinical Endocrinologists was giving us a data which may be preceding the European Society of Cardiology and European Association of Atherosclerosis, that the extreme risk patients, those who have progressive atherosclerotic cardiovascular disease, including unstable angina, maybe just like our patient, and those patients with established atherosclerotic cardiovascular disease plus diabetes or chronic kidney disease, and as I show you, our patient also is diabetic, we have a very strict targets that LDL cholesterol below 55, not only, this is the primary target, the secondary target, the non-HDL cholesterol less than 80, ApoB less than 70, and triglyceride less than 150. And I think that the American Association of Clinical Endocrinologists are much more meticulous than the European for getting the patient figures down to avoiding further attacks. So we have to remember also these figures very well as regard the LDL, non-HDL, ApoB, and the triglycerides. So what would your next step in the management of his dyslipidemia be? Because this patient, after the treatment with high-intensity statin and ezetimibe, is still 110 milligram per deciliter, and the target, as we saw, should be less than 55. And I don't like to say, in my opinion, because it is not evidenced yet, but it must be much more lower even than 55 to be 40. Because if you are talking that this patient is very susceptible to the second attack, he is like a pump. He is like a pump which will be explode at any time. So we have to consider the recommendation, even if it is 2p in the guidelines, to keep this patient maybe down to 40 milligrams. But let us say that our primary task is to get it to below 55, and if we are lucky and if we have the weapons to get it down to 40, I think it will be much more safer for him. This is also one of the famous slides that we have to initiate our therapy with high-intensity statin, which is a class 1 level of evidence A recommendation. If we don't achieve the target, we have to combine it with ezetimibe, and also this is class 1 recommendation. Another important class 1 recommendation, which is a step up for the level of evidence to be a level of evidence for secondary prevention patient at very high risk not achieving their goal on a maximum tolerated dose of statin and ezetimibe. A combination with a BCK-CA9 inhibitor is recommended. So here I'd like to say that this patient is kept on Rozova and ezetimibe, and he's failed to reach the target. So here by evidence, we have to add the PCSK9 inhibitor to reach the target. A very important slide here about the intensity of the lipid-lowering treatment. We have to know the level of intensity of the statin, because it will give us a percentage of reduction of LDL cholesterol. And also, if it is combined with ezetimibe, it will give us another percentage of LDL reduction. And if they are combined with PCSK9 inhibitor, they give us a third level of reduction. So we have to know the percentage of reduction, because by knowing the baseline of LDL, by calculating the percentage we need to reach, I think we will choose the what's called the high intensity lipid lowering therapy, not the high intensity statin lowering therapy, because in such subsets of patients, not only the level is important, but also the duration to reach this level is also important, because as we said, it is like a timed bomb. So we have to respect the time. We have to be earlier, because earlier is a better in those subsets of patients. If we have a lot to the high intensity statin, we can achieve a 50% reduction. If it is combined with the statin, 65% reduction. If it is combined with a PCSK9 inhibitor, we can reach 85% reduction. And by calculating from the baseline 220 milligram LDL, I think it will not be achieved by 50% reduction with high intensity statin because it may be 110. And even if we're adding ezetimibe, we will not reach the target of 35. And I think we will not able to reach the target except if we are lowering the LDL by more than 80 or 85%. And this will not be achieved except by adding PCSK9 inhibitor. When to reassess the LDL level, here also the guidelines is clear. We have to reassess after 4 to 6 weeks from the attack. This is class 1 recommendation, but what is very important here also that lipid level should be, as I said, re-evaluated 4 to 6 weeks after the ECS to determine whether a reduction is achieved or not. Safety issues needed to be assessed at this time and statin treatment doses adapted accordingly. Also here, if LDL goal is not achieved after 4 to 6 weeks despite medical treatment, and ezetimibe adding PCSK9 inhibitor is recommended. And finally here, for patients who present with an ECS and whole LDL are not at goal despite already taking maximum tolerated statin dose and ezetimibe, adding PCSK9 inhibitor early. So the guideline here confirming what I said in the previous slide, that early is much more better after the event, and if possible during the hospitalization for the acute coronary syndrome event. Why? Because they are respecting the statement of the timed bump, so the earlier is better in those subsets of patients. So as we said, the next step here will be the PCSK9 inhibitor. PCSK9 inhibitor, for those who maybe forget, because I know this slide is mentioned a lot, very simply that the LDL receptor which find in the surface of the hepatocytes, sticking to the circulating LDL, and this complex is go inside the hepatocytes to be vanishing the LDL and recycling the LDL receptors to be up again to the hepatocyte. What about if this complex is attached to the PCSK9? If the it will form what's called the LDL receptor, the LDL, the PCSK9 complex, and inside the hepatocyte, there will be a failure for recycling the LDL receptors, and all this complex will be vanished, and the LDL will not coming up again to the hepatocyte surface, and the LDL is keeping in the skipped in the circulation, which is elevating the level of the LDL inside the circulation. But if the PCSK9 inhibitor binding to the PCSK9 molecule, the normal LDL recycling will take place, and the LDL will be reduced in the circulation. This is the mechanism of action, very simple, of the PCSK9 inhibition. Now if we have data like this, these data should be supported by a strong evidence in the background. And in the background is the Odyssey outcome trial, the top line results, aliricomab in patients after acute coronary syndrome. And this is, I think, our patient. Age more than 40, acute coronary syndrome. This is criteria is also typical for our patient, acute coronary syndrome 1 to 12 months prior to randomization, high intensity statin, atorvastatin 40 to 80, rozova 20 to 40, maximum tolerated dose of one of these agents for more than 2 weeks, LDL cholesterol more than 70, non-HDL cholesterol more than 100, ApoB more than 80. And here I'd like to be back to the American Endocrinologists Association, that the analysis of the non-HDL cholesterol and ApoB is also important as secondary target for those patients. The the randomization here is for aliricomab subcutaneous every 2 weeks versus placebo, the running period of 2 to 16 weeks on high intensity or maximum tolerated dose of atorva or rozova. This is the way they randomize the patient. And here is a target range for the LDL cholesterol. Of course, the desirable target will be from 50 to 25. And there is an attempt to upregulate or downregulate the dose to keep the patient within the target from 50 to 25. And here is, if we look to this graph, the comparison between the placebo on treatment and aliricomab on treatment, we can find a significant, of course, reduction of the mean LDL cholesterol. And also, if we have a look to the very important means, like the coronary artery disease deaths, non-fatal MI, ischemia, stroke, or unstable angina requiring hospitalization, we can find here 50% relative risk reduction with number needed to treat MO48, which is 49, which is very considerable. And here is also for the all-cause this 50% relative risk reduction. And if we have a look here to the all-cause death by baseline LDL subgroups, for those patients with LDL baseline more than 100 milligram, I think the benefit will be much more, because the higher the baseline, the higher the benefit in comparison to those with LDL less than 80. Of course, the safety issue is non-significant between the two groups, without any affection for the liver enzymes, the creatine kinase. Also, what's important, the development of new onset diabetes or even worsening of diabetes, there is a negligible percentages between the placebo and aliricomab, only maybe for the general allergic local injection site reaction, which can occur with any subcutaneous needle prick to the skin. And the conclusion, of course, of this study compared to the placebo in patients with recent acute coronary syndrome, aliricomab 75 or 150 milligrams subcutaneous targeting LDL cholesterol level, as I said, from 25 to 50. And I think now in a lot of cases, in a lot of lipid profile, after penetration of the high intensity lipid lowering therapy, if I'd like to say, we can find in some of the lipidogram an LDL of 25 or 30, sometimes of 20, and sometimes of 15. And we have some reports of 5 and 10 milligram per deciliter. Reduced mesenchymal and ischemic stroke was associated with a lower rate of all-cause death, was safe and well tolerated over the duration of the trial. In the coming 2 or 3 minutes, I will give to you the final evidence of the evidence. If we would like to say that Odyssey outcome with a strong evidence behind the guideline, now in 2020, a few months ago, that presented in the American College of Cardiology meeting, the achievement of new European dyslipidemia guideline, low intensity lipoprotein cholesterol treatment goals after acute coronary syndrome, and this was insights from Odyssey outcomes. The background and aim, the 2019 dyslipidemia guidelines have recalibrated targets of lipid-lowering therapy, particularly for secondary prevention, as in our patients. And of course, in patients considered very high risk, we have to go down to less than 55 and maybe lower than 40 for patients with recurrent cardiovascular event within 2 years. And using data from the Odyssey outcome, we examined how many patients achieved these new goals with PCSK9 inhibitors. And I think without the presence of PCSK9 inhibitor, it was very tough to reach the levels below 50. And if you'd like to reach 40, I think it is a very tough job. This job, after penetration of the PCSK9 inhibitor and after the sub-analysis of the Odyssey outcome, they found that it is achieved those levels and projected how many would have achieved the goal with the use of ezetimibe. A total number of about 19,000 patients with recent acute coronary syndrome within the past 12 months, and LDL cholesterol more than 70, non-HDL more than 100, ApoB more than 80, despite intensive or maximum tolerated statin treatment, were randomized to elericomab or placebo. Level 2 less than 55 or 40 at any post-randomization time point, excluding patient treated with ezetimibe at the baseline. We projected the number who would have met guideline targets as baseline treatment with the drug, assuming an 18% reduction of LDL cholesterol from baseline with those with ezetimibe. If we have a look to here to the results, percent of patients who achieved LDL cholesterol less than 55 on at least one post-baseline measurements according to the baseline LDL, they are 94.6% on at least one post-baseline measure, compared to 17 only in the placebo arm. Imagine how much the achievement we got from using the elericomab in such patients, which I call them the timed bomb. Also here, the patient with prior atherosclerotic cardiovascular disease who achieved LDL cholesterol less than 40. So they also a study for those patients who reach less than 40 at any time post baseline according to baseline LDL levels. Of patients with at least one prior ischemic cardiovascular events, 84% assigned to elericomab achieved LDL at any time after baseline compared to 3.7 with placebo. So 84% can achieve the 40 milligram per deciliter LDL by using the elericomab. In conclusion, in patients with a recent acute coronary syndrome and residual LDL cholesterol elevation despite intensive or maximum tolerated statin therapy, the addition of elericomab allowed about 95% to reach the new 2009 European guidelines, because in the guidelines they give us the recommendation and let us use the drug worldwide, and then they restudied the some of patients after using the PCSK9, as I mentioned, 19,000 patients, and they found that about 95% reach the new 2019 European guidelines, which is 55, and about 84% reach the target of 40 milligrams. So it is not a dream now. It is not a dream to reach the 40 milligram per deciliter. And this is, of course, in contrast, the addition of ezetimibe prior to treatment would be expected to achieve LDL cholesterol in only 10% of patients at baseline. This is what happened with ezetimibe, only 10% of patients from the baseline. Final slide, the patient eligible for elericomab. Cardiovascular disease in combination with the statin and other lipid-lowering therapy in patients with unable to reach LDL goals with maximum tolerated doses of a statin. This is, I think, our patients. And of course, in patients with heterogeneous familial hyperlipidemia patient, and also in statin intolerant patients. And those two subsets are also important to mention and also important to know as one of the uses of the PCSK9 inhibitors. So finally, I'd like to repeat again and again, yes, the lower the better. Yes, we have to reach the target, but on those time bomb, we have to reach it earlier, because earlier is the better. And thank you for your attention.
Thank you, Professor Sayed. Actually, as you said, this is a case of acute coronary syndrome, so without any risk stratification, this is a very high risk. But I noticed that the LDL cholesterol is above 200, it is 220. So probably this is a case of heterozygous familial hypercholesterolemia.
Yes.
And this may make the even the things more difficult to be controlled. And I agree with you that in such situations, when the baseline LDL cholesterol is high, we should start with a combination therapy to cut the long story short. No need for starting high intensity statin first, then jump to the combination, jump to the alirocumab or PCSK9 inhibitors, because by any means, the high-intensity statin therapy would achieve around 40% reduction of the LDL cholesterol, which will not be enough. Even the combination with ezetimibe may lead to 60% also reduction LDL cholesterol. So I
have a
agree.
question, Professor Ashraf, for Dr. Said.
Okay, Todd.
If you allow me, Professor Said, thank you very much for your elegant presentation. My question is, we have substantial residual risk for myocardial infarction and coronary heart disease events for many patients, which remains despite the intensive guideline-directed medical therapy. What's your explanation for that?
Thank you, Professor Atif, for this very important question. And I think there is now a very important statement which come up to the stage, which is the statement of the residual risk. The residual risk is very important. And I think one of the important residual risks here, even if the LDL cholesterol, and especially in diabetics, if the presence of the high level of the non-HDL cholesterol and also the high level of triglycerides. That's why I'm really respecting American Endocrinologist Association, because they put a secondary targets, very clear secondary targets, than LDL, which is the non-HDL cholesterol lower than 80, and also the ApoB lower than 70, and the triglycerides lower than 150, especially in the extreme risk patient, I think like our patient. So I think in our patient, this patient, even he reached the target below 55, I think he will still have a residual risk coming from the non-HDL cholesterol, coming from the ApoB, and also from the triglycerides.
Why not from the affinity, from smoking, from the inflammation? Why?
I think different mechanisms of the, as you mentioned, Professor Atif, is responsible for the residual risk. It may come from the lipidogram, yes. It may come from the inflammatory process, because as we know now that there is a new concepts for the inflammation as a responsible for the progression of atherosclerosis. I think this is responsible for, because there is an inflammation theory now. So I think this is one of the theories that make the residual risk.
Thank you.
Dr. Atif. Dr. Said.
Doctor.
Hello. I have a question. Can
I?
Yes. Dr. Said, thank you for a brilliant case. I have an issue with the fact that this patient is smoking 1.5 packets a day, and all the focus of what you presented was medicines to lower his LDL. And I actually put that on the chat. I don't know if you had time to see it. Because if this patient's LDL is brought down to 20 and he continues to smoke 1.5 packets a day, I don't think it'll do him much good. You know, it will be, to be honest, it will be a waste of his money, especially that in Egypt he has to pay for it. There has been a recent paper about are your genes a death penalty by a group of authors. I'll put the link in a moment. One of them was Seth Palathian. And it's not true. Actually, very good lifestyle can actually really ameliorate your genes, even heterozygous familial hypercholesterolemia with LDL 200. If you have a patient, if you have two brothers and one of them is a non-smoker who exercises every morning for an hour and eats a good diet and controls his weight, and the other one is a heavy smoker, and both of them have LDL 200, in all likelihood, you're going to find accelerated atherosclerosis in the one who's a smoker who doesn't, you know. I'm not saying in any way that we should not use medicines, but I would hate for us to be focused on the interests of the pharma and on the guidelines of big societies, which some of them are very keen to put, change guidelines and drugs and, what about lifestyle? What did you do for this patient's smoking? Or did you just tell him, please don't smoke? I mean, I'm keen to know what happened to this patient's smoking status.
Totally agree, Professor Hani. It is very important, and that's why all the guidelines all over the globe, both the lifestyle modification and stop of the smoking, all of the guidelines all over the globe, like class 1 recommendation. No way to step up without controlling your lifestyle and the patient lifestyle, in conjunction, of course, with starting treatment, but you cannot step up without lifestyle control, especially for those patients with secondary prevention. Never to go without.
I know, but in Egypt, I know that everybody who is with us on the panel today does not have any tools more than saying to this patient, probably as they are leaving the clinic, oh, don't smoke, which is good. I think people should say that, but this occasional advice will work in 1 to 2% of patients. So because of pharma interests, we can actually give our patients PCSK9, but because there's no pharma interest in cessation of smoking, we don't have smoking cessation clinics. Actually, we do, but they're very, very few. And I would strongly urge this wonderful society to focus on lifestyle modification, which is non-pharma sponsored.
Totally agree.
And especially smoking cessation, weight loss, exercise, as much as we focus on medicines. Thank you.
Thank you, Dr. Said.
Thank you very much for your very
Dr. Said. Thank you for this thank you for this very interesting case, which is represent an everyday practice for us. However, I fully agree with Dr. Hani and Dr. Atif that the risk is multifactorial, not only hypercholesterolemia, which is sometimes may be difficult, especially in our circumstances in Egypt. So, do you prefer to try to him high-intensity statin as regards rosuvastatin 40 milligram in addition to ezetimibe before adding PCSK9, which is not available for each patient? In addition, definite for lifestyle modification. Again, it is not. It is.
Thank you. Yes.
You hear me?
Yes, I hear you, Professor.
Do you prefer?
Okay. Yes.
To give him a 40 rosuvastatin before PCSK9?
Actually, this is a very important question because, yes, we have some inertia. Actually, I'd like to frankly speaking to you, especially in Rosova, that we cannot, that we have inertia from jumping up from 20 to 40. I think, as you mentioned, that 40 milligram rosuvastatin will help us. But here I'd like to mention something. We have to know the percentage of reduction of LDL cholesterol we can get with the even Rosova 40. It is about 55% reduction. If we add to it ezetimibe, we can reach up to 65%, up to 70 reduction. If we look to our patient with baseline 220 milligram, I think even by calculation, by doing 65% reduction, we will not reach the target, unfortunately. So if we are looking for early reduction, the 65% reduction will not help us, unfortunately.
I with you, but sometimes it is impossible to give for each patient PCSK9 inhibitor, which is not available.
Yes, of course, you have to do all you have.
So,
yes.
So I do believe that is this an alternative scenario for treatment in such patients.
Yes. Sometimes we do our best if we have the weapon of
I think we still, Said, have 1 or 2 minutes for another comment or discussion, and allow me to add to the observation of Professor Hani Ragi about the importance of smoking cessation in the lifestyle modification. However, this is a case of secondary prevention. He was smoking for 30 years with diabetes and the bad lifestyles and ending with acute coronary syndrome. So at this moment, we should follow all the secondary prevention measures simultaneously. We should start with lifestyle modification, smoking cessation. Of course, he is in the hospital because he is acute coronary syndrome. He will not smoke in the hospital. But a smoking cessation program, a professional one, is very important in the future. But we should start with all the weapons we have: lifestyle intervention, smoking cessation, combination therapy, PCSK9 if available, because this is, as you tell us, this is a bomb, and the further events is expected in the future for such a very high risk person with bad lifestyle. So if there is no other questions,
Professor Ashraf, if you allow me,
yeah.
If you allow me, Professor Ashraf, I'd like to make a vote here for those who watched my case, who is agreeing with me that despite this is not in the class 1 recommendation or even 2A recommendation for the guidelines to keep this patient up to 40 milligram LDL. Especially, of course, as Professor Hani said, after controlling of his risk factor and stopping smoking and all the lifestyle measures we can change. But who is, if we do a voting, is preferring to go with this patient for 40 milligram and to all the measures?
But this is very difficult with this baseline, Said. The baseline, Dr. Sobhi want me to achieve 40 milligram. Hi, Dr. Sobhi, you are muted. Unmute your mic.
Hello.
Hello. We enjoyed the meeting of heart failure very much. Thank you for your effort, and thanks for the CVRAP for the marvelous scientific activity, Dr. Sobhi, as usual.
Thank you.
Dr. Said, back to you again. Baseline 220 LDL. It is a miracle if you reach 55 or 60 milligram per deciliter, I think, unless that is due to a bad lifestyle, not mainly heterozygous, but I think this is a case of heterozygous familial hypercholesterolemia. So, of course, all of us want to, the lower is the better. And 40 milligram per deciliter is better than 60 milligram per deciliter for such a person. But I think it is a very difficult target to be achieved.
Here, I'd like to know the opinion of Professor Sobhi. I know he didn't attend the case, but this is a patient for secondary prevention, like a time bomb with a cluster of risk factors, and he had PCI after acute coronary syndrome event. His LDL after 4 weeks, despite intensive statin therapy, is still 110. The baseline was 220. Would you prefer to start as early as you can PCSK9, or you will keep this patient on the high-intensity statin plus ezetimibe and follow up?
No. If he can afford, I can go immediately into PCSK9. I don't wait more than 4 to 6 weeks according to the guideline, the combined therapy. Because this is, and I agree, this is the second events or first event. If the second event, I go more rapid than I can. If first event, maybe according to our circumstances, I can wait for 2 months, 3 months according to finance. But if this patient reimbursed, so you can start to the base. So if you have a second, don't blame the combination. Go for PCS9. If the first attack and no response, think about it according and try your best to give him PCS9. But I think this is a treatment for the patient to reach below 55 otherwise. Because as you said, it is 200, I think, in LDL.
Okay. I think, Said, you have a long night today. So if you allow me to conclude this excellent, nice sessions, take a 5-minute break to be ready for the interesting CaseBox wave number 4. Okay?
Thank you.
Okay.
Thank you.
Hello, and welcome to the Proluent instruction video, where we show you how to use your Proluent pre-filled pen. Before using your pen, read the entire instructions for use found in your Proluent package and watch this video to make yourself familiar with each step. Those instructions, along with this video, provide fully detailed information about each step for treating yourself with Proluent. Use the Proluent pre-filled pen as directed by your healthcare provider. The steps for treating yourself with Proluent are the same for both the 75 milligrams per milliliter and 150 milligrams per milliliter dosage strengths. But in this video, we will show you how to use the 75 milligrams per milliliter pen. You should start with the dose prescribed by your healthcare provider. Proluent is a self-administered injection from the pre-filled pen that you see here. The pen includes a blue cap, a yellow safety cover, an inspection window, and a green button. To prepare, take the pen out of your refrigerator. First, look at the label on the pen, then check to see that you have the correct dose. Green 75 milligrams per milliliter for this pen, and check the use-by date. Then look at the window and check that the liquid is clear, colorless to pale yellow, and free from particles. Do not use if the window appears to be solid yellow. It is okay if you see an air bubble, but do not use the pen if it has been dropped or damaged. Now, let the pen come to room temperature for 30 to 40 minutes. Do not heat the pen, let it warm up on its own. Also, do not put the pen back in the refrigerator. When you are ready, gather alcohol wipes and cotton balls or gauze pads. Please make sure to have a puncture-resistant container available to put your Proluent pen into once you are finished. Ask your healthcare provider about the proper way to dispose of your used pens. Next, wash your hands with soap and water and dry them well. Then, take your pen and supplies to a comfortable, well-lit room where you feel relaxed. Sitting or standing is okay. Now, choose where you would like to inject Proluent. You can inject Proluent in your thighs, belly, except for the 2-inch area around your navel, or your upper arms. Do not use Proluent on skin that is tender, hard, red, or hot. Do not use the pen in areas where you have visible veins. Try to rotate the injection site each time and do not use the exact same spot as you used for your last injection. Once you have chosen the area where you would like to inject Proluent, wipe it with an alcohol swab and then let dry. Now you are ready to use your pen. Hold the pen in the middle with one hand. With your other hand, pull the blue cap straight off. Do not twist it off. Once you have taken off the cap, do not put it back on. It should be placed in the puncture-resistant container. Also, be careful not to touch the yellow safety cover. Put the pen like this in the palm of your hand in an upright position so that you can clearly see the window. Place the pen straight against your skin at a 90-degree angle and firmly press it into the site until you cannot see the yellow safety cover anymore. The pen won't work if the yellow safety cover is not fully depressed. If needed, pinch the skin to make sure the injection site is firm. Next, you are going to push and immediately release the green button with your thumb. You will hear a click, which lets you know the medicine is being delivered. Keep holding the pen against your skin after releasing the button. The injection may take up to 20 seconds. Watch the window. You will see the yellow marker moving as the medicine is being delivered. When the entire window has turned yellow, the injection is finished. You may also hear a second click. This may take up to 20 seconds. When the window turns completely yellow, you are finished with the injection and can pull the pen away from your skin. Now that you have finished, you may see a little bleeding. Do not worry, just hold the cotton ball or gauze pad over the site until any bleeding stops. Do not rub the area where you have injected Proluent. Be sure that you put the used pen in a puncture-resistant hazard container right after use and keep it out of the reach of children. Follow your local guidelines and ask your healthcare provider for the appropriate way to dispose of the container once it is full. Remember to keep Praluent pen and all medications out of the reach of children. Use the Praluent pen once only and then dispose of it properly. We hope you found this video helpful. It is our goal to help you along every step of your treatment journey.
Good evening, everybody, and let me welcome you in this fourth wave of CaseBox moderated by Professor Said Farag from the IAVA Society and Professor Julia Kraspa from ACC. And actually, this is very interesting waves. Actually, I enjoyed a lot being in the moderation of these sessions because we are seeing a lot of very interesting case. I would like to thank Julia and Said Farag for the arrangement of these fantastic meetings, and I hope it will be interesting as usual. So I will leave the mic to Professor Said Farag to present the program of today before starting the session. Professor Said Farag.
Thank you, Professor Ashraf. Really, I have the great pleasure to be between this bunch of really fantastic and elegant experts in the fourth wave of the CaseBox joint meeting with my dear friend Julia Krapsa, the chief editor of JACC Case Reports. And I think today we have a bunch of cases presented by Professor Walid Ammar, Professor Khalid, and Professor Ahmed Khashaba. And also from the JACC Case Reports, I think Julia will present them. And I now leave the mic not to take a lot of time to keep you enjoying those interesting cases. I will leave the mic to the moderators of the first session, Professor Sawhi, please go.
Okay, good evening, everybody. Thanks, Professor Ashraf, for the great effort doing IAVA. And thanks, Dr. Said Farag and Julia for preparing this CaseBox waves. Actually, it's important now in the COVID pandemic to spend the night even to show cases and go interactions, and we need chatting from the audience, please. I have with me Professor Hani Raghi and Professor Ayman Ahmed for sharing the sessions and making the panelists for discussion. Let's start with the first speaker, Professor Walid Ammar, Associate Professor of Cardiology in Cairo University. Is doing a case, endless case. This is a very interesting title, endless case, the best of the worst case. That all of us have worst case, but I know what is the best of the worst. Look for the Walid. Dr. Walid.
Thank you very much, my dear Professor Dr. Muhammad Sobhi and the chairs and the moderators of the session. My all thanks to Professor Ashraf Reda and IAVA, and my dear friend Dr. Said Farag and Julia for preparing such amazing meeting. Our case today is about a 62-year-old lady. She is hypertensive and not diabetic. And 3 months before her presentation, she had crescendo angina with poor response to treatment. She had normal resting ECG, and treating physician asked for stress ECG, which was highly positive. She had normal laboratory workup, normal LV systolic function with no segmental or motion abnormalities. As you can see from diagnostic angiography, she had chronic total occlusion of her LAD very close to its origin. She had moderate disease in the LCX and obtuse marginal branches. Some delayed antegrade filling through collaterals, and the right coronary was a large dominant one with ostial PDE moderate lesion that gives collaterals to the LAD. That in addition to the proximal CTO showing also mid-segment lung disease. The issue of revascularization options were discussed with the patient and her family, and we decided together to have a trial of PCI rather than bypass surgery for such patient with no diabetes and LED, which was not that great for bypass. We crossed the total occlusion. This case was done some years ago, about 6 or 7 years. So femoral approach was done by the time, and we crossed the chronic total occlusion with a pilot 150 after an initial trial of BMW wire, and post the proximal site of total occlusion and the mid-LED lesions were dilated using a 2 millimeter balloon, as you can see, and another wire was passed through apparently significant diagonal branch. Then the site of total occlusion was stented using a long 34 millimeter stent. It was post-dilated using a 3 millimeter balloon with spot at the takeoff of the diagonal branch. This was the LED after initial stenting of the site of total occlusion, and the diagonal branch to me looks a little bit significant, so I did the balloon dilatation with an intention of provisional stenting. If it deserves, I will go. And after balloon dilatation, it seemed to me that it needs stenting. Here's a story of a sequence of some obstacles happened during this case. We tried to pass 2.25 millimeter balloon in order to have tab stenting for this diagonal branch. However, despite adequate ballooning of the LED stent with NC balloon and pot and opening the struts, we couldn't pass the stent across the struts to the diagonal branch. And on attempting retrieval of the stent, it slipped from its carrying balloon and dropped in the left main. We tried to retrieve it. The next step was to try to retrieve this dislodged stent, passing a small balloon, 1.5 millimeter balloon. The balloon succeeded to pass across the stent. However, during trials of retrieval, the balloon used to slip from the stent, and the stent finally was crumbled despite several trials. Finally, the stent, this dislodged stent, was foreshortened and crumbled in the left main. So at this stage, we stopped to think about another maneuver to retrieve the stent or to what to do with it. We thought about crushing it with the balloon or crushing it with a DAS in the left main, or try to pass another balloon or try to deploy the stent using a balloon through it. And the final decision was to retry to pass another larger balloon and retrieve this dislodged slipped stent. So we passed 2.5 millimeter balloon, passed through this crushed stent. Fortunate enough, the wire was still inside the stent, and we tried several times to retrieve it. Finally, we were able to retrieve the stent into the guiding caster, and it came out with the two wires, that of the LED and the diagonal branch, and everything was in the guiding caster. And it was a very long journey to maintain the dislodged stent captured by this balloon in the guiding caster. Now, if you can see, the stent is overstretched part here and a very long filament segment. Then we have part of the stent here. We retrieve and pulled everything down across the thoracic aorta, abdominal aorta. Now it's very, very overstretched. If can you appreciate, its beginning is here, its end is here, till we reached the iliac artery. Then the stent was about to be dislodged from its balloon. So the final was to snare this stent. We passed the snare through the sheath to retrieve it. However, the crushed stent and the snare and the wire were all bulky to go through the sheath. So the only option at the time is to remove everything together with the sheath. So we removed everything, the sheath with the snare and the crushed stent outside. The next step is to insert another sheath, whether to go from the same side or the opposite side or the radial approach. Actually, the patient was on high dose of anticoagulants, so I tried to go through the same puncture, and fortunately enough, we succeeded to pass through the same puncture with no resulting hematomas, and we inserted another sheath. And this is a picture of the retrieved stent over the snare. You can appreciate how it was overstretched over the wire. It begins here and goes all the way. This is the snare stent. However, during this stage, the patient developed severe chest pain and became progressively hypotensive and passing into shock. So when we cannulated the left main again, we found that the LED became totally occluded at the stented segment as before. The patient started inotropic support with dopamine infusion, and because of acute thrombotic event, we started intracoronary and intravenous glycoprotein inhibitor tyrofepan. We passed the balloon through a wire and the balloon through the LED stent. We dilated it again, and the patient started to stabilize. So by this time, I decided not to go to the diagonal branch again. I leave it early. It has chemistry, and go to the distal LED lesion and dilate and stent it for 2.5 millimeter balloon. And the final angiographic outcome was satisfactory. However, the story was not ended by this stage. On the second day, this first case took about 3 hours. We went for a case revision on the machine to understand what happened, why all these complications happened. The patient by this stage, on the next day, she was stable in the ICU with no chest pain, no ECG changes. She was hemodynamically very good. What we realized is that during withdrawal of the dislodged stent, what happened is the LED stent actually came out, or we have a big suspicion of that. The LED deployed stent, not only the dislodged one, the two stents came together outside the left main. So we brought the explanted material. We kept them for the company, and we examined them. They are actually two stents intermingled or intertwined, attached together. I have no explanation how the two stents became attached to each other, one deployed and the other one not deployed, and they came together as one unit all through the journey from the LED down to the iliac and femoral artery. We realized that actually after removal of this stent, there is no shadow. We have just calcification. So the big thing was how to convince the patient and the family to have another look again after doing this horrible PCI. They were easily convinced, thank God, to have another coronary angiography 3 days later in another cath lab with a newer machine for better resolution. And you can appreciate that we have a dissecting flap in the proximal LED at the site of the previously deployed stent, and the distal LED stent is pretty patent. So we passed again a wire, and we dilated the LED again, and we deployed another stent in the LED and post-dilated. And final angiographic outcome was satisfactory, and we hope this was the end of this case. And thank you very much.
Thank you, Dr. Reed, for this very nice case, and also that you revised the case after. Again, this is it's very wise from you to see what happened, and astonishing that you found this, which is I think this is the material of. If the lesion preparation was successful first in this patient, you don't find any calcification because you did this and did pot, and nothing happened, which prevents the stent to cross the diagonal. I don't know why this happened. We have to explain the first one. The second already cannot be detected except by your revision. The third, the best you did, and the patient was stable. Though the patient was stable for 3 days, which is strange also to have this patient like this. Can you have explanation to you, or we can discuss it with the panel? We can take the opinion of the panel first, Dr. Hani and Dr. Ayman, and then you answer this. Hani, you have Any opinion about what happened to this case?
No, it's difficult to tell because the nuances would be only known by the operator. And I think they handled it very well. With the newer generations of stents and the material we're using now, we're seeing less and less of slipping stents. And Professor Eid Ammar just mentioned something really, really important. He said that they brought the patient the second day for look in a better cath lab with better imaging, which means that the case was done in a cath lab in which he was not 100% comfortable with the imaging equipment. And that is something that I think we should take into consideration, that in Egypt, in many instances, we have to work under suboptimal conditions sometimes. And I appreciate the skill in finishing this case.
Dr. Ayman.
It's good for the patient.
Okay, Dr. Walid, I think, first of all, I want to thank you very much for presenting this case. Second of all, I think you've done a great job ultimately managing each very complex situation along the way. You had multiple complexities, multiple issues, and you've handled them wonderfully with an excellent final result, which is what really counts. Now, for us as academicians and operators, we always, as you did, like to go back and look and see, well, why did this happen? How did it happen? Which is basically why you're presenting it and why we're supposed to comment and give personal opinions. The first issue will be what happened with the stents? Frankly, as soon as you said the stent came out, the first thing that crossed my mind was, I wonder what happened with the LED stent. Because you said we had proper pre-dilatation, we ballooned the ostium first of the diagonal, and then we felt it needed a stent. So you have ballooned it with like a 2 millimeter balloon, at least, correct? Can you hear me?
Yes, I hear you. Initial
Yes.
2 millimeter balloon.
So this should have been more than enough to pass a 2.25 stent.
Yes.
For the stent not to cross means it got tangled, probably a strut from that 2.25 millimeter stent got tangled inside with a strut from the LED stent, that's why, frankly, I was not surprised at all. And I kept looking for the stent, for the LED stent, and I couldn't see it. And then you said, we realized the LED stent was not there. What I believe happened is you had a strut from the 2.25 millimeter stent that shabaket got entangled with the LED stent. Now, why should that happen? How did it happen? It should be crimped when it comes from the factory, and it should not get stuck with another stent. For that to happen means that somehow, when it was crossing, I've seen this happen with people who connect the indiflator to the stent before crossing the lesion. The indiflator is connected, and sometimes it will inflate the balloon by like half atmosphere. And when that happens, it stretches some of the struts a little bit. And then when it crosses, you have a strut that is not compressed. It becomes elongated, and it can get easily entangled in the struts of the LED stent. When you try to come back, it's sort of like a fish hook, and it pulled the LED stent, leading to a dissection flap. This dissection flap was unstable and eventually closed later. To me, this is what I could imagine as to what was the scenario that led to her being okay for a couple of days and then occluded the stent, occluded her LED. I don't know. This is my thought.
I have an explanation, if you don't mind, Mohammed. You are lucky that this is a recently deployed stent, because I've seen cases and case reports, a stent avulsed from the artery, with even having material within it. But this is a recently deployed stent. Sometimes a spike of calcium just hits the proximal part that the second stent got entangled with, and then pulled everything out because it was a freshly deployed stent. We've seen such cases, and you were lucky enough not to have avulsion of the artery, and this is a fatal thing. So it's a well demonstrated case of how underdeployed or heavily calcified areas can harm your stents, even if they are of the new generations.
Walid, you answer.
Thank you for all variable comments. First, your question, Dr. Sobhi, why didn't the stent to the diagonal branch pass? Maybe related to this type of the stent. This case about 6 years ago was not one of the FEB approved stents. Maybe this is the reason. We did good pre-dilatation, as you can see here, through the struts, and we did the pot, but it didn't pass. Why both stents came together? I think it is related to inflating a 2.5 millimeter balloon, as you can see. I'll show now. In this, on the right side, here the balloon is dilated, part of it inside the LED stent. I'm catching the dislodged stent with this balloon, but it is inflated inside the proximal segment of the LED stent. And when I pulled it to pull the dislodged stent, it pulled also the LED stent because it is inflated.
Okay, that makes sense.
Yes.
That makes sense.
Okay, I think I have just looked at the program, and I'm afraid I have to interrupt these very interesting discussions and go to the next presentation, Professor Khalid Tammam, so we can take...
Can I introduce him?
Yes, please. Hani. Stop sharing, please, Dr. Walid, and Dr. Khalid Tammam share.
Thank you, Dr. Walid, for this nice case. Thank you very much.
Okay. I just want to... Thank you, Professor Walid. Shall I proceed straight away, ICOM, or do you want us to have your 30-second thingy?
I think we are online. ICOM.
Okay.
No, it's okay.
Wonderful. Okay.
Go ahead.
I just want to re-welcome Professor Julia Graspa, MD, PhD, FACC, who reminds me very much of Professor Khalid Tammam's also endeavors, reaching achievements at a young age. Dr. Graspa was a consultant cardiologist at age 32, and where? In Cambridge, UK. And she is one of the youngest editors of JACC Case Reports. And since she's here, I actually would ask all of you to try and put your cases in JACC Case Reports. They're wonderful cases, and you have a friend there. So we welcome you to be with us in Egypt, and we're very, very proud to have you here tonight.
Thank you so much for your kind words. I don't deserve them, but thank you.
No, you do. I mean, your journey from Greece to England to, I've been following it, and it's amazing. It's written in a small story in JACC. If anybody can Google JACC Julia Graspa, you can read something interesting. I'll send you the link. Thank you. And when it comes to Khalid Tammam, this touches a especially emotional chord in my heart, because I remember the first time Khalid, as a young man, entered the cath lab. And maybe I was one of the older cardiologists and was his mentor. And I also remember just a few years after that, Khalid coming back from his trip to learn in Korea and Japan and teaching me radial. And, it was one of the happiest days in my life to have my student teach me. And since then, he became a complete top gun. And I've learned so many things from him. But I really do remember him as a very young man in the very early days in the National Heart Institute. And he's never, ever lost his humility and his kindness and his niceness. So it's always a fantastic pleasure to see Khaled, even though he's in Saudi Arabia and not with us at the moment. But please go ahead and share with us your presentation about how to deal with coronary perforations. Thank you.
I cannot do a presentation now. No, it's first of all, thank you, Dr. Hani, for always supporting me since starting. Dr. Sobhi, Dr. Adil, all of you, Dr. Khashaba, Walid, all of Dr. Ashraf Rida, Sayed, and all of my
just give us the presentation, Khaled.
Yeah, okay.
We love you.
Okay, me too. So Sayed always give me a difficult topics to finish in 15 minutes, and how to deal with different type of complications. So let's share my screen quickly. Okay. So when we talk about the perforations, always talk about the word of Colombo. If you don't have a perforation, there is something in your techniques. So usually all of us have a good perforations, which can be what's mean good. It's like type 1, without extravasation, small wires, can be dealt even when we leave. It's good. There is nothing happen. Or we have an intermediate perforation like type 2, which is the extravasations can go outside and there is a myocardium blush, and the contrast is in extravasations, and the patient start to be a little bit stable or unstable. Or type 3, which is frankly perforations, or type 4, which is a patient is unstable hemodynamically, whatever you did for him. So if we go quickly to review what's type of how to deal with a type 1, if a patient is stable, always we are in the good side. That's with a small balloon inflations. It's okay, but all with what we are recommending for our young fellows or all of intervention cardiologists, please, when you have any kind of perforation, please don't be panicked. The key of success, not to be panicked, because when you panic, you try to do something wrong, and the patient start to become unstable, or sometimes you do something which can be dealing with a very small thing. So type A stable, we will with the inflator the same balloon of sand balloon, of course, or the same balloon of the balloon you dilate, whatever you use, and you just low pressures and just keep it for a while, sometimes up to 30 minutes. Then you check and you see if you need a cover stand or not. If it's unstable, that's something else. So we have to prepare and when we have the perforation, always we have to prepare the tool of perforations, including the graft stand, pericardium, pericardiocentesis, call for the surgery, echo, and all this. Type 2, again, what we say is that the start to have extravasations outside, again, if the patient is stable, and always all patients, male, strong man with good LV function, always they are stable. So don't worry. The problem always with the young ladies, obese, those patients always they have a problem. So you have to, even they are stable, you have to be careful that it will not be easy to be done with the same. So stable, we do the same. We inflate for long time. Prepare the graft stand, because usually type 2 will not finish with a balloon only. Time you need a graft stand, and you have to check. Finally, you have to check with the echo that has a tamponade, if they have a tamponade or not. If an unstable, inflate the balloon and start to have a pericardiocentesis. Try to have another axis to start to have a big bone techniques. What we will show in the latest in these presentations, and start to have your echo and your call your surgeon to be standby. when we go to type 3, always the patient is hemodynamically unstable. So usually we have to call the surgeon, we have to call the anesthesia, to echo, to inflate the balloon for the long time. Again, until you prepare all this, your balloon should be inflated. Never, never, ever inject to check your side for the 10 minutes. And you have to consider after 10 minutes, you inject a very small puff. And the bit to bring the patient from stable to unstable, you have not to inject any of contrast. Oh, when we go to class 4, type 4, that's this, whatever you did, the patient is unstable. So you put a graft stand, the graft is not, you inflate the balloon, not working, graft not working, then your extravasation, maybe you are on the outside of the artery and your stent is all outside of the artery. It means there is something wrong. So you have to call the surgeon. You have to see where you are. Sometimes you are in the cavity. You have to prepare the surgery. Sometimes we open the patient inside the cath labs. So if we see that with the type 3, that's 63% of these patients, they have a tamponade. So when you have the type 3, you have to prepare the precarditis. And be careful that post-cabbage patients, sometimes they don't bleed in the pericardium, they bleed outside. So you have to do CT chest to check where you are, because sometimes the bleeding is outside. So perforation calcifications, it's a main vessel sometimes. If we are oversized or eccentric calcium, we post rotablators. Distal wire perforation, especially in the MI, collateral perforations when we do retrograde by epicardium or the septums. So I will show you quick cases of this one. I think it's type A lesions, which is very easy one. But again, when we see this kind of the vessel, which sometimes maybe is the intramural course, we have to take care about the post-land dilatations. Usually we like to be perfect. Pre-dilatation, very smooth. Nobody imagined stenting. And then after stent, we find this kind of perforations. So huge perforations, and this one is almost type 2 to 3. But lucky enough, because it's male, if you see here in lateral view, because this biplane, I don't take a 2 view, so we can find huge extravasations. Simply here, by stent balloon, we inflate for like 10 minutes. Of course, patient has a pain, ST elevations, but you can see it starts to be sealing. So while the patient is still stable, even he has a chest pain and the ST elevation, but don't panic. Just the key of success in this case, don't panicking. Finally, good sealing with only balloon. When we think about the graft stand, you have to put also in your considerations, it's safe view, but sometimes the patient has an in-stand stenosis in the long term. And of course, he has some dissection proximally, and then we cover with another stand. And this patient, even he don't need a pericentesis. Again, if you see here, this patient was a male, 77 years old. So it's old man. He had a good preserved, and this is different to lady with obese. So if we go to CTO, different kind of perforations. Again, this patient was done during one of my live transmissions. And we have, this is a very short segment CTO RCA, an old man. who has a lot of devices, including the CRT, the R3D. And we thought that the anti-grade, it will be good for him. This case was done in France. We find a good collaterals for him. I hope you can see the image.
Okay, good.
Yeah. So this
We
have to increase the support, we put a wire in the RV branch because the microcaster was not easy to pass through this after the wire passing. So we try to increase the support. So we put the wire in the RV branch and we make an anchoring balloon by 2.5 balloon to the RV. Here's the wire start to pass. Wire successfully passed to distal artery, distal through lumen, without any problems. But the problem was the support. And as you can imagine here, that's our balloon. It's in the RV branch to increase the support. However, we was very happy to just put the stent. But when we look here, we find there is some extravasations outside, maybe from manipulation, pulling back and put the balloon to main artery. This balloon has been pulling back and cause RV perforations. Again, we try to have here just sealing for the main artery, just RV not be more. You see here, there's some extravasation here.
You pulled the wire out, yeah, Khaled?
The wire was pulled out, yes.
Yeah.
For RV, the wire was pulled out. And then we have this kind of image. You see? A lot of the huge dissection with perforation of the whole RV is perforated. Can you see it?
Yeah.
So the step, as we see in the algorithm, we put balloon the main artery here, and just to seal that's RV, to close the RV, while the patient is hemodynamically stable. But again, the perforation is more increasing. So at that time, while we put the balloon, I go with the left radial, and I have another guiding in the same times from left radial. We are in the right radial, so I'm going from left radial, and I put another guiding GR4, and while my colleague has been deflate his balloon, I pass another wire here, and I was, just because the artery is open, and then he inflates the balloon again. This is called ping pong technique. I think Dr. Ahmed will talk after this one, after me. So I put two guiding, I pass the wire, and I pass another one, and inflate the balloon again. So we have a two guiding, two wires, and the balloon is inflating there. And then we prepare the papyrus stent. Graft stent, and we start to inflate without any losing of contrast at the same times. Then another one, you have we put the proximal one, and we don't inject. And we put the second one while we have we are not sure that the first one was not inflated. And this is the final image. And the patient was saved without any pericardial effusion or tamponade. So always we have to take care about the anchoring wires. Always can have a big trouble during CTO. So how to avoid coronary perforations? We have to check first the size and your wires where they are, and you have to make sure that your wire escalation. This I will talk later. How many minutes I have to just, because I have one more cases to show?
No, I think you finished. I think you finished. Yeah.
Can conclude, Professor Khaled.
Conclude, yeah.
So treatment of perforations, balloon dilatations, dual catheter. Sometimes it's observe your techniques. If you need ping pong techniques, of course, if you have only balloon and you can't seal it, you can make something with your give protamine or something for the anticoagulations. IV fluid is very important. Don't do any complex lesion without having in your cath labs cover stand. I have the last cases, remaining cases is for coils for the coronary perforation in the CTO. So you have to, if you decide to do CTO retrograde, you have to have coils in your cath labs. Sometimes something to close this pericardium or septal perforations.
Somebody's unmuted. Somebody's unmuted and we can hear them. Please mute yourselves. Okay, carry on, Dr.
Be having your friend you have to call for help when you have a coronary perforations. You prepare yourself for the big tail to put pericardiocentesis, and please don't be shy to call the surgeon whenever he needs, because sometimes patient can be saved when you call the surgeon, especially when you have the type 4 perforation. Thank you very much.
Thank you. Thank you very much.
Thank you, Khaled. And let me first welcome Professor Adel Atrebi. He's a professor of cardiology at Shams University. He's a past president of the Egyptian Society of Cardiology and chairman of the working group of interventional cardiology. And I will leave the mic for him to lead 1 or 2 minute discussion with Professor Khaled, then presenting the next presentation, Dr. Adel.
Thank you, Ashraf, and thank you, Saeed, for inviting me. This case is very educational, and I think what I really do is every time I inflate a stent and deploy it, I keep the balloon in the stent and do just a puff of injection to be sure that nothing is happening to the patient, because by this anticipating perforations and rapidly inflating the balloon will make inside the area of perforation will help you to avoid tamponade and pericardiocentesis and make your patient still stable, and then start to decide what to do next. I think this is the best way to handle perforation, is to anticipate it first and be ready for it by always injecting with a deflated balloon of the stent before getting it out of the stent. That's what I usually do, specifically if I use a sizable stent in a relatively small vessel.
I have a question, Professor Adel, to you
Yes.
and to Dr. Khaled. Recently, I was called to see a case, and I walked in the cath lab, and there was an RCA with a free-flowing perforation, okay? There was a stent, I could see a stent, and I panicked. I was gonna scrub to help the operator, but he said, no, this happened 2 weeks ago. I said, what are you talking about? And he says, yeah, it happened 2 weeks ago, and it's not in any, it's not in the pericardium, it must be in a cavity. It's an amazing video. I actually have it, and we'll probably send it to Jack Case Reports. So anyway, at that time, the operator, for reasons many reasons, he had decided not to treat the perforation. The patient was stable, things had happened, and he left this free-flowing perforation. It's a free-flowing perforation. It looks like an AV fistula. And I have the original film before the perforation of the stenosis, into a cavity. It's into a cavity. So maybe into the RV, I don't know. So now, a few weeks later, asymptomatic patient with a pinpoint but free-flowing perforation, puffing contrast all over the place. What would you like to do? Would you like to close it? Or would you like to try and see where it's going? And how can we know where is it opening? I mean, how would we know which chamber it is on? Do we have to do like the congenital heart disease people, do an oximetry everywhere, or would the CT show it? I would love to share this case with you, but this is my question to you. Has anybody seen a perforation, a huge perforation, I mean really free-flowing, left untreated and causing no sequelae?
Yeah, I have.
Yeah.
Well, actually, Hani, this will act as an AV fistula, so it will definitely cause some myocardial steal because some of the flow will go definitely into this fistula, and it's definitely into a low chamber pressure organ. So it's either in the right atrium or in the right ventricle. You'll never know, but it's still, I think it will cause a steal phenomena, and you have to do something about it. To diagnose it, the best way is by CT angio, and you can see where the contrast passes exactly. And I have a case like this. I left it actually, but it was not that huge. It was just a simple clearing of the contrast every time I inject into the vessel.
Adil, I have a comment. I have a comment to thank you, Khalid, for these nice cases. But I have some comments regarding the perforation. Because I think we have 150 audience. Maybe most of them doing catheter. I don't know how many perforation they have. They saw. Number one, take care of perforation, take care of the wire and the use of the wires. Number two, don't do a high pressure with except with non-compliant, not with a compliant balloon. Number three, you have to do lesion pressure. As Adil said, Professor Adil said, I have the same, doing it some buff to see that don't leave the balloon. Number five, you have to train in your cath lab how to deal with the distal perforation rather than the proximal, because this is the most difficult perforation. You have to have coils, and you be trained in the 1 or 2 types of coils. Sometimes if you don't have coils, you take a fat from the thigh, and you make some dilution and put this fat inside the artery distal, sometimes with the microcatheters. Or you have a glue from your neurosurgeon in your cath lab. These 3 important parts to be used in the very distal perforation, which you cannot do have a covered stent. If you have a perforation after a covered stent, still you can do another covered stent inside the covered stent. Sometimes you have 2 covers. This is also in the guidelines, in the PCR guidelines, management of perforation. So you have 1 cover stent with different sizes. 2, you have some techniques for the distal perforation.
There are some short reports about putting a drug-eluting stent inside the stent graft, so that because the main issue with stent grafts is restenosis. And
last week I asked Antonio Colombo who had claimed this. He said this is what in the past, Muhammad, I didn't do it again. Because I heard from Antonio Colombo, as you said, that you can put a drug-eluting stent inside the cover stent to prevent restenosis. But he told me, no, I'm not doing this again anymore, because I have a long study that this is not effective for the patients.
Professor
Muhammad, let me just to comment. One, when something wrong happen, it's happened. Huh? Whatever you prepare, whatever it's when it's shit happen, it's happened. And so it's whatever you are, Colombo, best guy in the world, you will have it in your life. Whatever you do, this kind of procedure, you will have it. The problem that you always, when you have on shelf cover stand in your cath labs, always expired, and you may don't face it for 2, 3, 4 years this kind of perforation, and finally you find you have a two different size of a stent and is not fit with your anatomies. That's the main issue. So always when you do the cases, you don't have full size of your stent. You don't have the.
Khaled, I changed everything. Sorry, Khaled. This is the job of the manager of the cath lab. You have to make it.
But you don't have a full size. Not full size.
No, 6 months before.
Not full size. You have a 4 or 5.
Yeah.
I think we have to move because we are late on time. I'm sorry about
please, Adel, go ahead. And
yes.
Thank you, Professor Khaled Tamam, for this.
I have seen a case with Khashaba that he was using part of the balloon to distort it distally. I saw it. Dr. Ahmed Khashaba is a professor of cardiology at Ain Shams University, my university, and he is one of the experts in intervention and specifically in innovations and good and new ideas for management of complications. I've seen a lot of cases from him. Dr. Ahmed Khashaba is giving a nice title, which is When Ping Pong is Not a Game. So can you tell us what you did?
Thank you so much, my dear professor and my dear professors and colleagues. I'm very proud to be with you tonight and to share with you some of the work that we have did. Let me please share my screen, and this is actually fits very much in the timeline of the presentations, and after Dr. Khaled, very great presentation about how to deal with perforation, because this is actually a case about one of them. This was a 56 years old gentleman, obese, as Khaled mentioned. He is dyslipidemic and had PCI to the LAD 8 years before this index presentation. He presented with effort angina and NIHA class 2 with negative troponin, and he is also a smoker, hypertensive, type 2 diabetic, and he had the previous partial nephrectomy. This is his left system, as it can show patent stent in the LAD, multiple irregularities everywhere, but actually no other specific stenotic lesion in the left system. And this was his right. It is a medium-sized right coronary, gives a small PDA, still a dominant right coronary, with a ugly lesion in its middle part. And this is the lateral view of the right coronary. Seems nothing in particular. Calcium can be seen hardly from the angiography. So we went straight forward for the PCI. We prepared the lesion with a 2.5 by 20 semi-compliant balloon, and again to have a good preparation of the lesion, another 2.75 by 20, followed by a 2.5 by 24 drug-eluting stent for the distal part of the vessel, and another 3 by 24 drug-eluting stent for the proximal part, and this is after the 2 stents. The distal stent is reasonably inflated or expanded, but if you take a look to the proximal one, some still irregularities and under expansion of the stent. So we went for a balloon post dilatation with a 3 by 10 non-compliant balloon for the proximal stent, and this is again after the post dilatation. Still, you can see the indentation and under expansion angiographically. You don't need an IVUS to see this. So, but it's there by angio anyway. So with the same balloon, we went for re-optimization for the stents, and with a big R of the patient with the same balloon, and you can see here the balloon is not yet removed from the artery. Just after dilatation, we have, as Professor Etribi mentioned, we have a look, and you can see a free floating perforation in the mid of the RCA. So we just inflated immediately the same balloon, inflated again just to control the situation, and immediately I introduced another guiding utilizing what we call the ping pong technique, which is which gives you an alternative pathway to do the work while you are still occluding the perforation with the first balloon. taking the time that we left the initial balloon for like 10 minutes to, as Khaled mentioned, to try to control the bleeding. But again, with a small buff after 10 minutes, still the perforation is there. Again, following the protocol that Khaled just mentioned, we had a look with the echo that's always available in the cath lab, and you can see starting of accumulation of the pericardial fluid, despite the fact that there is no time wasted. The balloon is immediately inflated. The guiding is the second guiding with the ping pong. The guiding is introduced, but still there is accumulation of flow, giving you an idea how massive the flow is, and it's the time, the seconds that you just deflate the balloon to see how the perforation is causes this accumulation. So we started just to deflate the proximal balloon. We inflated another proximal balloon and keeping minimizing the time and trying to have some more time and to inflate with a second balloon in the proximal part together with the distal balloon. But this is of no good, and still the perforation is there. So we decided to pass a covered stent inside exactly the location of the perforation, and we inflated the covered stent. And this is actually also didn't stop the free floating from causing a tamponade, and the hemodynamics of the patient started to be compromised, and the blood pressure came down, and a recheck of the echo gives you an idea why this happened. And so we just started the pericardiocentesis. We drained the pericardium while the covered stent was inflated in place, and the patient has some hemodynamic compromise, a little bit of bradycardia. But after we completed the pericardiocentesis, he regained again the rhythm, the pace, and the contractility, and this is after the completion of the pericardiocentesis. This helped to control the perforation, and with a little bit of a slow flow at the end of the procedure. In contrary to what Khaled mentioned, I just permit me to take the other direction. I do not revert the hip. Yeah, I don't revert, because you have all the gears inside the patient, and you don't want to end up with having intracoronary thrombosis. You get rid of the perforation, but you get another problem. So we try to keep the ACT at around the 200 and 220, so not less and not more. This is by the end of the procedure, a little bit of a slow flow that improved by the end of the procedure with intracoronary nitrates after the blood pressure just came up. This was the end of the procedure. Just to make sure everything is fine, this was in the beginning, and this was in the last picture in the procedure. 3 months later, I got the patient to make sure how everything is going, and to see if any restenosis is starting to form despite that 3 period. But with the graft stent, the incidence of restenosis is a little bit high. But let me remind you that this graft stent is put inside, not an outside of a 2 drug-eluting stents, and this is, I think, a way to minimize the rate of restenosis for these kind of procedures. So this actually an angio 3 months after the perforation happened, and it showed a very nice flow inside the artery with no residual slow flow. I'll skip this slide because Khaled just mentioned all the type of presentation, and just jump to my take-home message is that the perforations do occur. Prompt recognition and management is life-saving, and the new technique of proximal ballooning while doing the distal manipulations at the side of perforation is a helpful way to do or to complete the case successfully. Thank you so much for listening.
I agree, Ahmed, with you about the reversal of anticoagulation. I never do it again. And the lessons also from this, you have to be very rapid in doing the pericardiocentesis. So you have to train yourself in different cases, just not during the coronary interventions, how to do the pericardiocentesis in emergency. because this step is an important step, the life-saving for the patient, because precarditis in a chronic patient differ from precarditis in acute patient. And also the guiding catheter is very important. The echo is important. I have a just case from maybe 1 month ago in my cath lab, some perforation, and I couldn't do pericarditis in the usual way. So a suggestion from my colleagues, the young colleagues, that to do it an apical part. So I do an apical pericarditis with guided with the echo, and to be sure that you are not in the right ventricle, you have to do some a saline wash out to see if the saline going the right ventricle, so you are puncturing the right ventricle and not puncturing pericarditis. I have just one case in the TCT-EP last week. I'm moderating these complex PCI cases, and there's a complication for the patients during PCI perforation, during pericarditis. Patients survive, and there's a big puncture of the right ventricle. So he put an implanter device in the puncture of that. So also we have to be trained how to close the defects while doing it. Thank you very much, Ahmed.
Well,
for this
I think Ahmed, that leaving the balloon have saved your patient, because this was a huge perforation, and if you couldn't diagnose it early, you could have lost your patient. So I think it's a must when you do over inflations or long inflations to keep the balloon deflated and have just a puff to see it. We have in our department a very huge experience, unfortunately, with tamponades, because we started balloon mitrals in the 80s, and they're having a lot of tamponades in our early training period. So we are experienced in tamponade management, me and Ahmed, in this. But this is not a good experience, because you don't have to see a lot of perforations to deal with. But anyhow, I would like to thank you, Ahmed.
Actually,
if someone have any last comment.
Yeah, I have one comment about the mechanism of the perforation, and this is very important to have. And I think what happened here is spare of calcium that was not very apparent in the coronary angiography by the angiographic machine is what caused the pinpoint perforation in the mid RCA. Calcium is the enemy, and this might take me back to Walid's case, because actually what I do think what happened in Walid's case is that again calcium was there in the LAD, and while inflating, maybe one strut caused fracture in the stent, in the LAD stent, in the first one, and when it was introduced the second one, this fractured strut that could never be seen with angiography hanged with the second stent. And that's what caused the second.
And I have Ahmed, we are passing time, so I want the last comment from Walid Ammar.
Yeah, can I also say a comment?
Okay, but very quick comment.
Very quick.
Thank you, Ahmed. It's very nice to see you after this long time, and Khaled also, and all my dear professors. I'm trying to ask all of you about the predictability of coronary perforations after we finish the case and the patient leaves the cath lab. It's twice to leave the pigtail or not, and when to do that, how frequent to follow with echo, and how to anticipate the short term of this perforation, especially if a small one or large one.
Can I answer this question, or do you want to answer it, Dr. Khashaba?
Yeah, please, Hani, go ahead.
Okay, you have your final comment and answer also. So
okay, I actually I've done quite a few perforations myself, and I never leave the cath lab if there is still blood coming in the pigtail. My patient will never go to the intensive care unit with a pigtail catheter coming out of near their belly button inside, because this is basically the job is not finished. So we do the pericardiocentesis if we have to. Now, as we get more experience, we don't even need to do pericardiocentesis in the majority of cases, because we use the technique you described, the ping pong, or other techniques that Khaled has described. So in the majority, but if somebody else had done the perforation, you rush into the lab and the patient is full of fluid, I would do everything possible to make sure that this patient does not require an ongoing catheter under vacuum in the pericardial fluid, because I think this is asking for trouble.
We always leave a pigtail in, even if
I
as Dr. Walid says, that sometimes after, even if you finish, when you get back to the room, and then start bleeding again. So leave a pigtail for 24 hours is a must.
No, I never leave the pigtail in. I totally disagree. If the patient bleeds again, they will tamponade again, and I will bring them back to the cath lab. But they're unlikely to bleed again. But leaving the pigtail in is a dangerous practice, and I think it could induce a fatal pericardial infection. I mean, especially in Egypt with the pigtail dangling on the floor in our wards. I mean,
it's our common practice to leave the pigtail in. Don't worry.
I've done many perforations. I've never ever left the pigtail in once in my life.
I answer this. I was doing the same like Adil since the last 2-3 years when they found that there is a pericardial infection, and then nowadays they said what you are telling us: don't leave the pigtail and sheath. Don't leave the patient with the cath lab suspected of still doing bleeding, or still perforation. Wait, and then remove the pigtail and sheath and go out. That's
last comment from Khaled, and then I will leave the mic to Said.
But my comment was that I have caused the perforation when I tried to stent a very ischemia-causing intramyocardial bridge, and I presented that case in TCT. And the stent was the proper size, and it was not over high pressure and everything. And it was a super duper perforation, which was fixed by stent graft. So the message is never stent myocardial bridges, even if they're causing myocardial ischemia.
My last comment. Actually, again, if you go through my presentations, patience. Take your time in the cath lab. Sometimes we send the patient to surgery while the balloon is inflations because we don't have a graft stent. We go there, we open the chest, we find everything sealed, and we go out. Yeah. So this, because we are hurry, we are panicking, we are afraid about the perforations. While the patient is stable, stabilize the patients, put the pigtail, have your team in standby, and do the echo and work in peace. While you are panicking, you get the problems. We start to have a problems. We put undersizing or oversizing of the graft stent.
Well, Khaled, this is a never-ending discussion. So I'm sorry, I have to interfere and leave Dr. Said to start the next session.
Thank you, Professor Adil, Professor Sobhi, Professor Hani, Professor Walid, Professor Khasha, Professor Khaled, for this really a very delicious meal of cases with a bunch of perforations and slept stents, how to deal with these complications. Thank you so much. Thank you for great paneling. And I think now we have to move to the coming session, which will not be less than this one, with the fantastic cases from the JACC case reports side. And I will leave the mic after a break of 2 minutes to my dear friend Julia to present the coming session. So please, we will go for a break. And before a break, we will take a photo, please. Just smile. Okay.
Inhibiting PCSK9 with Praluent to reduce LDL-C. Since its discovery in 2003, proprotein convertase of ptyrosin kexin type 9, PCSK9, has been shown to play an important role in targeting LDL receptor for subsequent degradation. Proprotein convertase of ptyrosin kexin type 9, or PCSK9, acts by reducing the amount of LDLR at the cell surface of hepatocytes. PCSK9-mediated degradation of LDLR, a complex of LDL-C, LDLR, and PCSK9, is internalized into hepatocytes, into clathrin-coated pits. After endocytosis, the affinity between the receptor and PCSK9 is much higher than that observed at neutral pH. The PCSK9 C-terminal domain plays a pivotal role in targeting LDLR for subsequent degradation. Molecular interactions within the PCSK9 LDLR complex, thereby enhancing receptor degradation and consequently increasing circulating LDL-C levels among carriers. PCSK9 has become a target for lipid-lowering therapy. Praluent is a monoclonal antibody inhibiting PCSK9 by preventing it from binding to the LDL receptor. With the decreased PCSK9 activity, LDL is able to disassociate from its receptor within the hepatocyte, allowing the LDL receptor to be recycled back to the cell surface, where it can bind more LDL, thus decreasing LDL-C levels. Praluent, which binds to and inhibits PCSK9, became a target for lipid-lowering therapy. Please refer to Praluent insert leaflet.
Welcome back. I'm quite pleased now to have three speakers, including myself, actually, together with my friend, colleague, Professor El Said Farag. We designed this session of complications because we feel that we learn from mistakes practically. So now we will present a series of structural intervention complications, and I'm very happy to have two great friends and colleagues that I know them for more than 15 years. And I will start with Dr. Dimosthenis Pandis, who is Associate Director at the Clinical Research and Education at Mount Sinai in New York. He joined us from United States. Thank you, Dimos.
Good evening. Thank you, Julia. Good evening, Cara. Thank you for the organizers and for Jackie's reports. It's really a pleasure being amongst this esteemed panel and colleagues and friends. And I'm sad that we can't do this in person and we are constrained behind screens, but I hope and wish everyone will be okay, and we'll meet probably next year under better circumstances. So my task for this evening is to share a few cases about mitral complications. I'm a surgeon by training, so I will not dare to venture into the structural interventional procedures, but I would like to share with you a few operative complications with regards to the surgical repair of the mitral valve. It's a structure that's surrounded by an anatomy that might potentially cause, if we're not careful, complications, perioperative complications during the procedure and after the procedure, just by the geography of the mitral valve. Now, to begin with, I just want to show you a few cases of three types of complications. The first case is an old lady who came as a straightforward mitral valve repair, prolapse, degenerative mitral prolapse. She's had a long history of atrial fibrillation, and as you can see, aside from having normal coronaries, she is left dominant. So this lady had a typical type 1 Carpenter type 1 dysfunction or annular dilatation. So we did a mitral annuloplasty and took care of the atrial fibrillation perioperative. She had a size 30 mitral annuloplasty band and a tricuspid valve annuloplasty. Now, during the repair, we had an abrupt onset of arterial bleed that you can see here from a modified 4-chamber view. Something was showing that the retrograde cardioplegia balloon was compromised, and that's what we saw in the operative field. So we have bright red blood coming from the back of the heart. This is a dreaded complication, and because of the position, we're not we don't have the luxury of doing many things. We cannot displace the heart very much, so we had to go ahead and do a primary repair of the rupture. But it was closed, it was addressed, and as you can see here, we've coming off bypass. The left ventricle is struggling. Now, at this point, there's a lot of thoughts going through our heads on how we're going to address this. So the first thing we do is we'll go back on bypass, and we're trying, and knowing that the patient had frail tissue and type 1 dysfunction, what we did, I'm just going to go further up. What we did is we just remove this part of the annuloplasty band that is right at the crux of the circumflex, and try and release the pressure that might have caused some kind of compression of the coronary structure. And here is the echo coming back after the second run. So the ventricle is still sluggish, and at this point, what we did is we just put a balloon in place. We went to the ventricle, went back to the CICU, where we had a stable, unfortunate increase of troponin. So we had some persistent signs of myocardial injury. And at this point, we went to the cath lab. And as you can see, there is a distal tethering of the circumflex artery, which was successfully repaired with the help of our colleagues on the cath lab, an interventional cardiologist, and a stent placement. Problem was solved well. The patient came back 30 days later, and everything was fine. The second case that I want to show you is a younger female that had exactly similar pathology on the background of a healed endocarditis with degenerative mitral valve prolapse. She had a normal coronary anatomy with the right system, 0 Agatston score. You can see that aside from the prolific anterior prolapse, she had some congenital hypoplasia of the posterior leaflet. So she had a straightforward repair with a complete ring in this case, and a suture annuloplasty of the tricuspid valve. Now, again, coming off bypass, we see that the ventricle is a bit struggling. So we didn't have any hemodynamic compromise at this point. And after some augmentation, we filled up the ventricle, and with a moderate dose of epinephrine, we went back to the CICU, where we noted the first signs. So we didn't have the signs in the OR, no EKG changes, but we did see those as a few minutes after coming into the intensive care unit, but the patient remained stable. So despite cracking up the inotropic support, those changes did not improve. And at this point, we went back to the cath lab and see, not back actually, we took the patient to the cath lab, and we saw something interesting. As you can see, before we said that the patient did not have an annuloplasty band on the tricuspid. She only had a modified De Vega suture annuloplasty. But what we saw on the right shot, there is a spasm of the proximal segment of the right coronary, which was successfully addressed with intracoronary calcium blocker infusion, which improved both EKG and the patient himself. Now, this is a beautiful case that it was presented submitted and presented, accepted to JAC case reports by Salvatore Borcoletta's group at the University of Barcelona, which shows a similar procedure. You can see that the patient has a proximal amputation almost of the left circumflex after a minimally invasive repair of the mitral valve. And in this case, the group had an ingenious use of IVUS for the navigation and placement of the coronary stent, which resulted in a perfect abolishment of the symptoms and anatomy. And I would invite you to see this and many other very interesting cases that Dr. Grazza has been kind enough to share with us and our readers. I want to switch gears a little bit and going away from the ischemic changes that we often see, but I mean, not often, but more often than others sometimes. And I want to show you this case. This is a 60-year-old lady who had a nothing special in her background aside from unknown degenerative mitral valve prolapse. So she came to us. This is her baseline transthoracic echo. You can just see torrential MR. Atrial dilatation, but otherwise nothing specific. So she had an elective case, but the point is that the moment that she was being induced, right after the first shot of epinephrine, the patient just started having some runs of VF, which then organized to sustain VF arrest, ventricular tachy and then VF arrest. which prompted basically Code Blue, which had to revive the patient. And while we were doing that, we actually called one of our EP electrophysiology colleagues into the room. The patient were intubated very quickly, and you can see here that we had a global injury of the left and right ventricle. So this is a sustained myocardial problem in an otherwise healthy, apparently, ventricle where the patient not only had degenerative mitral valve disease. And at this point, with the help of our electrophysiology colleague who identified the phenotype of the patient's ectopic activity, we put the patient on a balloon pump and went back to the CICU. Of course, we did not proceed with the procedure itself. But what came from this was a teaching moment from us. This is about 3 years ago in 2017. And what he educated us with is that we can see this strongly positive phenotype of the ectopic contractions, electrocardiography, EKG signal in the inferior leads, which it's consistent with the origin of the papillary muscle. And in this case, once that was identified, we sent the patient for a cardiac MRI, and it showed that lead enhancement. We had lead enhancement with signs, which means of replacement, a scar on intramyocardial scar. So the patient went back with a permanent ICD to recover, and came back about 6 months later for an elective procedure. The reason I'm showing you this is that I wanted to share with you what the actual papillary muscle looked like in a patient that has what we call arrhythmic mitral valve prolapse. You see the scarring appearance of the papillary muscle, which is not what the normal papillary looks like, and went on, and the patient had a normal outcome. And of course, this led to continuous series of these patients, in which we now have a very careful diagnosis, management, and therapy. Now, the third thing I'd like to share with you is, aside from those very unique cases, a common complication after open repair is the residual mitral regurgitation after the primary repair. And this is something that your compatriot and our colleague and dear friend, Dr. Ahmed Al-Ashmawi from I think the University of Alexandria. He's here. He's our director of clinical director of the structural valve of mitral repair reference center here, and he presented this data last year at the in Toronto at the AATS, annual AATS meeting, which basically shows not only our experience with the residual mitral regurgitation of the primary repair, but a very helpful algorithm on how to assess and manage this patient. And I'm just going to go through with you a few aspects of what complications you might see right after the repair. And the first thing we'll look at this patient is whether the residual repair is due to SAM, systolic anterior motion. That usually, if it's the patient is optimized hemodynamically, basically drop the heart rate, fill the ventricle, and then usually, hopefully, the SAM will go away. And this is an example of this case. You can see this is a type 1, again, mitral prolapse. Now, this is the echo right after bypass. You can see this LVOT obstruction from the anterior leaflet, which then that improves once the ventricle was filled, and that was resolved successfully. Now, in case that after those management steps, SAM does persist, then we do always go back and try and address it more aggressively. This is one of these examples. Unfortunately, I guess this is not going to play. Doesn't matter. So, sorry. Let me just see if this can play. And I will share the screen with you right now again. this is the case. So the patient had a 29 simulus, which basically means a 34 conventional sizing. You can see a very good depth of coaptation following repair, but we have an LVOT, again, obstruction, which does persist after filling up the ventricle dropping rate. And in that case, we actually had to go back and displace the posterior leaflet into the ventricle so we can move the line of coaptation away from the LVOT. And this is the actual outcome. We did not do anything to the leaflet itself aside from moving the coaptation in posterior annulus. In this case, again, you can see a prolific bileaflet prolapse of this patient. This is what it looks like. She had a straightforward repair with an annuloplastic band. We have a SAM coming off bypass, so we can see progressively dropping the rate. But unfortunately, MR persists, SAM persists. And in this case, we have to go back. We went back and we did a myomectomy. And as you can see here, we also removed the side arms of the annuloplastic bands so that we free completely the aortomitral angle so that the expand the anteroseptolateral dimension and move the line of coaptation away of the LVOT. And following those maneuvers, you can see this is the part that we did the proximal myomectomy that was sufficient to resolve the problem. And if now the case that we have persistent MR after the index repair and it's not due to SAM, then the first thing is after we hemodynamically optimize the ventricle, we'll try also to optimize the LV function, so we increase the inotropic support. But if that doesn't solve the problem, then we look at the MR itself and proceed on a case by case. And what that means is that if the MR is more than mild, we don't think twice. We will always go back and address it because the known detrimental outcomes of more than mild MR following repair in 2 to 5 years after primary index repair. So in this case, we have a straightforward generative mitral MR. We can see here repair with a complete ring. Now we have this jet that's coming right into the field, right from the proximal part of close to the hinge of the posterior leaflet. And what that translated to is basically that was just a torn suture that led to the dehiscence of the leaflet repair, which was primarily closed and successfully addressed. Now, in case that the residual MR after the primary repair is mild, then the way that we address this problem is we look at where the MR is coming from. Anything that is coming from the area of the leaflet itself or close to the annuloplasty, well, you always have to go back and address it because even if it's mild, just by the continuous blood flow, this will just increase and it will always end mathematically with the patient back in the OR. So here is an example of this case. Again, a straightforward repair. This had a P2 prolapse and a triangular resection and annuloplasty. But you can see here we have this angry jet coming right from the posterior part of close to the annuloplasty from the posterior leaflet. And what that looked like is, again, some deficit of the or leaflet was a little denuded from the repair, and we had to primarily close it, which successfully addressed the problem. And if, again, now the leak comes from close from the annuloplasty, and here's an example of that, you always have to go back and address it primarily. So this is an old gentleman who had a typical type 1 mechanism of prolapse, very frail tissues, and you can see this very angry signal coming from right on top of the annuloplasty. And when we went back, what we saw is that there was a little bit of a tear right here at the last suture of the annuloplasty that caused a small hole into our leaflet, and we just closed it primarily with a reinforced of pericardial patch, and that was successfully resolved. Now, if now the MR is coming from the closure line, this is just a case-by-case approach when the MR is trace or mild. So in young patients, we'll always go back, and nobody leaves the OR with more than trace or non-MR. But if a patient has comorbidities, like if it's an older gentleman has been, or you've been on bypass for a while, and a second run might be detrimental, if the MR is just mild or less, then we'll go back. We will just leave it as it is. And this is the typical case when we went back, and this is not going to play, but it doesn't matter. That was the idea, that we just primarily repair this. So with this, I'd like to thank you for your attention and for the privilege of the floor. And I'm happy to take any questions.
It was like a tsunami of wonderful images. I think, from imaging perspective, this correlation from the surgical imaging and what we know from the existing literature is wonderful. Any comments?
Yes, thank you, Dr. Demos, for this nice constellation of cases of mitral repair. How much the imaging can help the surgeon to optimize his results for mitral repair. I have one question about the ring annuloplasty, because it could be done in the past through percutaneously by cardiac catheterization, and one of the main drawbacks is the circumflex occlusion. But in surgery, I think you have an open field. You have tips and tricks to avoid the injury of the circumflex. I don't know what's the mechanism during surgery. Is it due to sutures, due to compression by annuloplasty ring? How could you avoid this complication of the left circumflex occlusion during surgical annuloplasty?
So thank you. That's a very thoughtful question. So the first thing that we can use to avoid these problems is to know very well the anatomy of our patient. And one is to know the anatomy of their coronary circulation, whether it's the right or left dominant, which will tell us whether or not the coronary or the circumflex is more close to the mitral annulus, or if it's on the right side and you're thinking of doing a tricuspid, common tricuspid, if we have to be thoughtful of the RCA. On the other hand, when it comes to the annuloplasty per se, it's the way that we will choose and we will hold our needles. Now, we don't have time to go extensively on this, but there is a way that we are thoughtful in the way that we do the annuloplasty sutures, so that we go always perpendicular onto the plane of the annulus. In that way, that we always direct the needle towards the ventricular wall and into the ventricle, rather than diagonally, because the course of the coronary, although it should be, you can see the cartoons in the literature, is very parallel to the annulus of the mitral valve. It's not always the case. There are oscillations of the difference and distance of those. So as long as we have the needle looking towards the ventricle, then we're safe to say that we can avoid those injuries. On the other hand, in cases that we are expecting to have difficult exposure, and that means either the patient had a previous aortic prosthesis and there was a bulge around between the 9 to 12 o'clock, so you won't be able to expose that part and put your annuloplasty sutures. You have to be thoughtful of maybe choosing not a complete ring, which means that you won't have to put annuloplasty sutures in that quarter of the annulus, and just go around and do either an incomplete band instead. With regards to access for open versus transcatheter, the use of catheter approaches for annuloplasty is still very, very good in very expert hands. And I will always say that those of us that have the experience or have the experience and training to know the anatomy in open field, only then we would be able to have a better appreciation of what we do if we use the same annuloplasty approach, but through a catheter device. So we have to always be thoughtful. Imaging is crucial. Imaging was crucial before, but it's so crucial during the procedure. So we depend on our anesthesiologists. We have training in the United States. I mean, in Europe, it's different. We need to, people like Julia Grafsa that has extensive experience. So we take cardiologists into the room in the OR to do the imaging. But in the United States, the anesthesiologist, the cardiac anesthesiologist is board certified for cardiac imaging. So we depend on them to tell us, like the one that we had the problem with the coronary sinus. If there is a fear of or a suspicion of a coronary compromise, it's very, very, I know because I've seen it, not because I can do it, but it's very important and easy for the anesthetist to look at the course of the coronary and see if there's any flow derangement. So trust your imagers, ask your imagers, do not have the ego that I can do it. It will save us and it will save your patient from a reoperation.
And I want to remember that in 2005, Dimos was teaching me how to take the SVG graft from the leg because I was doing cardiothoracic surgery. So it was interesting.
So, well, with this comment, I have to say that I said before that a structural interventionalist should know very well anatomy, and that you can only do this with open access. Julia is the inverse. She is a specialized triple certified imager with training in cardiac surgery. And I can vouch for that because we've spent how many, 3 years together?
3 years in cardiac surgery, yeah.
Cardiac surgery.
So interesting.
So I always trusted her. I always trusted her opinions.
To ask Julia?
Yes, shall we move? Sorry? Shall we move to the next speaker?
No, Dr. Walid wants to ask a question.
I'm sorry, my apologies. Yeah, I have my apologies.
Okay, Dr. Walid.
Okay, Julia. Thank you, Dr. Dimos. We are lucky to have a cardiac surgeon with us today. I would like to have your insights regarding early post-operative paravalvular leak after mitral valve replacement of mild and moderate severity. What do you think regarding conventional medical treatment and close follow-up versus endovascular or surgical intervention?
So paravalvular leak is a real problem. If we're talking about an annuloplastic prosthesis, and if it's an early appearance, this is a technical problem. It's always a surgical failure. So we always say that regardless of the origin of the phenotype of the complication, if it's really right after the surgery, something went unseen in the OR or developed early and was not flagged. And in this is an unfortunate case for the patient, but I have to say that I'm biased. I'm biased because for me, it's difficult to have an opinion with regards to the interventional access, because I've only seen very, very good results in those in the hands of those that have been doing this for basically pioneer the field. Now, if the paravalvular leak, for example, is optimal, the only reason that if it's mild, it will become eventually, if not in 1 year or 2 years, it will come back to you in 3 or 4 years. Hemodynamics are not forgiving. If there's a paravalvular leak in an annuloplasty, that means either there's you also have to look at where the leak is. If it's at the end, if it's near the commissures, that means it will signal that there's probably a dehiscence or a slip of the annuloplastic prosthesis right at the arms of the edges of the band. If it's right in the middle of the body, then it's more than certain that there's a dehiscence or a suture failure. It doesn't matter if it's mild or moderate; it has to be addressed. If you are lucky to have an experienced interventionalist, I wouldn't see a problem. You can see very easily. You can occlude this if the patient is a high risk for to go back on bypass to do an ambulatory device and close this. We've had cases that we increasingly do this very successfully. Again, in those patients that you don't have or you're concerned about getting them back on bypass or on the ventilator. If your patient is young, and by young mean if the patient is in their 50s, they have miles ahead of them. So we need to be thoughtful of a definitive approach that will last more than they will. If you have a 75, 80-year-old, then the risk of doing this, putting them on the ventilator and on a bypass, might warrant a little bit of thinking. And those might be a better cases for interventional approach. But if your patient is young, I will definitely veer towards an open procedure for a durable result.
Okay, and is the best time for that is an early or a delayed one?
Actually,
or healing of the tissues.
So if it's early, like we said, it needs to be addressed immediately. If your patient is old with comorbidities and you're worried about getting them back on the ventilator or on bypass, then yes, put him on choose the transcatheter approach. But if they're young, we need to be thoughtful of a definitive approach. If the appearance is late, I don't recall having paravalvular leaks in annuloplasty repairs coming late into the course of disease, into the course of the postoperative period. And that is because as the time goes by, the annuloplasty band becomes epithelialized. So if anything, if there is no paravalvular leak in the beginning, then there will not be in the end. If there
would
is
you agree that a late one is probably a missed early one? They probably just missed it, right? Most of the time.
I would find it difficult to say that someone missed a Doppler signal. That you must have missed many eyes, because it must have missed your nurse who saw you on follow-up in 2 to 4 weeks after surgery. It must have missed your cardiologist when you went back on 1 month after follow-up, and then it missed your primary care physician on 3 to 4 months. I haven't seen them in annuloplasty repairs, particularly like late appearance of paravalvular leak for annuloplasty. If it's a prosthesis, yes. But not an annuloplasty. And regardless, again, I think the everything is possible. We're all, we're humans. Things can always, they surprise us. I think the approach is exactly the same. It all depends on how confident you are to put your patient on a bypass and how long do you want this approach to last for. But I am excited with the field of interventional cardiology. We've seen the technologies make strides. The wires are now even, tinier, and the dexterity of the interventionalist is just beyond imagination. So I would be very confident in calling our friends across the room to give a shout before we do anything. We always have to discuss this together.
Perfect. Thank you so much. Apologies that we'll have to move to the next speaker. Thank you for the great presentation and the great discussion. And I would like to welcome my very good friend and colleague, Professor Saverio Muscoli. He's a professor of cardiology at the University di Roma Tor Vergata in Rome, Italy. And I know him for many years. He's one of the founders of ESC Cardiology of Tomorrow, and he's been in several committees in ESC, and he's also a senior editor for JACC case reports, and he will present the interventional complications. Thank you, Saverio.
Thank you. Thank you. I share my screen. Good evening. Thank you, Julia, and thank you all the faculty for the kind invitation. I agree with you about the complication and case report. We have to talk about this because talking and maybe publishing to share our knowledge about complication, we can avoid for the future other complications. So I have no conflict of interest. And today I talk about two nice cases. About the first case is about a transcatheter closure of a iatrogenic right ventricular perforation performed with an unplugged duct of the second. So our case is about a male, an old male or 81 years old, presented with a recurrent episode of syncope for last 15 days and shortness of breath. The patient was asymptomatic in the past and he was not taking any medication. And presentation, the patient was conscious and cooperative. The heart rate was 30 with a complete heart block. So temporary pacing was placed with a 6 French pacing catheter, a BARD in this case, so a 6 French sheet in the right internal jugular vein. Under fluoroscopy with a good threshold with 1.1 volts on 0.5 milliseconds. And so after this pacing, the ECG was having a paced rate, and so a standard situation. But in the same days was discovered a COVID-19. So the patient was positive, and on day 8, the patient developed hypoxia and required oxygen supplementation. Then was performed an high resolution CT thorax that show a typical infiltrate of COVID, and the CT show also that the pacing Y was protruding into the pericardial space with pericardial effusion confirmed also by echocardiography. So the pacing threshold was 1.5 volts. So from day 9 to day after 2 weeks. So after 2 weeks, on day 15, there was a lot of pacing, but there was no worsening of effusion, and patient was stable. So another pacing Y were introduced, and this time from right femoral vein, with a classic approach from femoral vein. So yeah, we discussed about cardiac intervention. So iatrogenic cardiac perforation is one of the major complications of cardiac intervention. So in this situation, surgical correction of perforation is a standard of care, and we know this. But in these cases, was discussed with the art team because was the COVID-19 pandemic, and an open heart surgery was a high risk due to age of the patient, 81 years old, and COVID-related condition of the lung involvement. So was decided to perform a transcatheter intervention as bailout measure. So on day 18, the patient underwent removal of right spacing from interjugular vein after informed consent with, of course, a surgical standby. And as we can see, a baseline angiogram of right ventricle did not reveal any leak, which is formed in these cases with a right catheter, and coronary angiogram show no flow limiting lesion into the coronary. And here we can see where is the first temporary pacemaker outside of the pericardium. So was performed the procedure. So first, the proximal end of right intrajugular vein pacing Y was cut, and the 6 French sheet was upsized on a 9 French sheet, and the long 7 French, the Avanti, in this case Concordis, was introduced over pacing in the right ventricle, and it was placed just short of facing right section. Then, as we can observe, a position of C positive in pericardium was confirmed with the contrast injection, and the pacing was exchanged, in this case with a wire, with a Terumo wire, which was positioned into the pericardium. And in these cases, the sheath was withdrawn in right ventricular apex, keeping the glide wire into the pericardial space, and the angiogram showed the opacification of both right ventricular apex and the leak, as we can observe, into the pericardium. Then the sheath was immediately advanced into the pericardium over the existing glide wire to seal the stick. And the operators decided to closure and to seal with an unplugged ductal occlude the second. It was a 6-6 into the was an abbot, and was introduced through sheath into the disc, and the distal disc was opened into the pericardium. As we can observe also the probe for a transthoracic echo, and then the entire device was pulled back for the standard maneuver, so the disc was again into the right ventricular pericardium. Then the device was released along the length of perforation, and proximal disc was against the right ventricle and the cardium in the cavity. And then the angiogram showed no leak, so in the pericardium, the patient was stable, the aortic pressure was acceptable, and right ventricle pressure also. So after 5 days of attending, the patient was implanted with a permanent pacemaker, and after 10 days, the patient was discharged, and the follow-up after 6 months was also good. So the discussion about this situation, which is, so first of all, the present complication, of course, was the result of prolonged use of temporary pacemaker. In ideal circumstances, a permanent pacemaker usually is planned at the earliest possible to avoid complications. Then, inside, a balloon-tipped temporary pacemaker maybe would have been a better choice, because usually it's less traumatic, according also our experience, and usually the 5 French is not a 6 French, but it's less traumatic. Also, when we have to stay a temporary pacemaker over 1 week, so in a standard situation, we try to avoid to have a temporary pacemaker for more than 7 days. So, talking about the device, the closure with a double disc device was preferred for a better stability. Also, ventricular septal device could be also a choice, but the operators preferred the unplugged ductal occluder for its profile, and post-deployment, the device was stretched significantly, where the ADO had advantage over the ventricular septal defect device. As we can observe in this image, in fact, the ADO device has the expanded spheres on both sides, reducing the chance of embolization. In such situation, should be very, very useful. Although surgery is the most preferred option, there are few reports about closure with the help of glue or other device. But nowadays is, of course, the standard of care. But the presence of this hardware, this device in a cath lab, as well as expertise, is sometimes should be life safe for transcatheter closure of perforation, and this should be very useful, I think. And this brilliant case was published recently on JAK case report and was from Dr. Balgat, Dr. Karsh, and Dr. Agrawal. And so I think that it is very important because is another option that we give to the patient when surgery is prohibited. And I want to talk about another case that is sometimes this time is about coronary, and this time we have an iatrogenic aortocoronary dissection during percutaneous coronary intervention. So we have a 70 years old man, previously fit, that was presented to the doctor for a classical stable angina with a, as we can observe, a standard care, standard medical therapy, aspirin, statin, beta blockers, nitrates. But despite this OMT, the symptom persisted and decided to perform an angiogram. And the angiogram, as we will see, we will observe soon, the angiography showed a severe stenosis in the right coronary artery behind the Shepherd's cross state or proximal course. And the echo was normal. So was performed the angiogram. We can observe the image better. And this was performed with a JL. And you can observe the Shepherd's cross. Then the angioplasty was performed with a NAMPLAS 0.75. And we can observe a dissection of the aorta and of the ostium of the right coronary artery. So here we can observe the manager, the angiogram manager, putting two wire, one in the first lumen and the other one was in the 2 lumen, and then through a microcatheter, the operator performed a stenting of the ostium on the right coronary artery, but persist the dissection of the aortic root. So we have to talk about this situation. What is an appropriate PCI strategy? So first of all, in this situation, use an unplugged should be the right choice, of course, because we have to increase our support. Other option should be the use of bad wire support, so to put 2 wire, or a guide catheter extension to deliver equipment, so a guideliner, for example. But if we have a dissection, so first of all, we suggest to rapid reassessment of the patient's clinical state, then passing a coronary wire into the 2 lumen. This is mandatory. Don't lose the lumen to maintain the access in the vessel for selling the dissection flap, and should be attempted, of course, also with a balloon. And we need, of course, it's mandatory, an echocardiogram bedside into the cath lab, and we have to perform it because we have to know if we have pericardial effusion, if we have cardiac tamponade of acute aortic regurgitation. So, that advice, request an urgent consult of surgery, because the heart team, the urgent heart team in this situation, I think is mandatory. And then we have, I suggest to request assistance from an expert colleague, because as we can see in the previous presentation about perforation, for example, or about dissection, this should be sometimes a nightmare with hour of procedure. So we need an expert operator. So in these cases, the initial attempt to wire the right coronary arch with a B&W, with a workhorse in the false lumen, in these cases, sometimes the operator use a workhorse of a soft wire like a B&W, But in these cases, the operator leaves the wire into the false lumen like a marker and engage the two lumen with a C on blue. In this situation, maybe it's more performant than the B&W. So, third, what is the next step after angioplasty? But first of all, it's very important. We need imaging because we know to start with the surgery, we need to sometimes we need an urgent CT that is very important. And in these cases, the initial attempt to deliver a 3.38 science, in these cases, maybe I suggest if you don't have a confidential with a guideliner, for example, like in this case, don't waste time and maybe use 2 shorter stents or use a body wire because sometimes long stent into this right coronary artery is not so a fast solution. So in these cases, they use a 6 French guideliner to deploy the stent, and after this, the CME3 was attempted. So the operator performed a rapid CT. This is a AMDR, the immediate CT performed that show a dissection, as you can observe here in the arrow, of the right coronary foot and the aortic roof, and a large mural hematoma in the mild ascending aorta. Then, at 24 hours, the patient was stable, so you don't have the emergency to put the patient into operating room after RCM consultation. The patient was stable, so after 24 hours, a CT was repeated and showed almost a complete resolution of the situation with a thin rim hematoma, as we can observe in the D, remaining in subintimal spaces. So, in conclusion, guide catheter induced aortocoronary dissection is a recognized complication of PCI, and operators should remain vigilant in a patient with risk factors. So, I suggest, especially for the younger, if you have no confidential with the amplas, especially for the right coronary artery, maybe stay with a senior or maybe try to use a body wire solution or a guideliner, because sometimes if you see the movement of the operators with the IL without a wire to be too fast maybe, and so sometimes I discourage to use amplas for the younger, because sometimes to be managed IL need some expertise, especially for the right coronary artery. So thank you. I think.
Thank you so much. Wonderful presentation. Very interesting cases. Any questions?
And also this, Julia,
yes,
also this was published on Case Report recently from John Young and Joel Gilbert from UK. Thank you.
Thank you so much, Professor Masculi. Again, 2 excellent cases. For the first case of temporary pacemaker, I wonder what's the rationale behind leaving a patient for 8 days on temporary pacemaker while the etiology is very clear. It's a degenerative 81 gentleman without any ischemia that should be waited to resolve. What's the rationale behind leaving this patient 8 days without permanent pacemaker? This is my first comment about the first case. And the second one, what is the backup strategy if this duct occluder was not functioning and still there is a leak from the RV perforation? Thank you.
Well, in my hospital, we have a similar situation, and we discuss a lot with the electrophysiologist, because I think that also 8 days because the COVID disease, because COVID is always an infection. And so we know that electrophysiology user didn't want to implant a pacemaker in the infected patient. So is a very discussed situation, the timing of a pacemaker and LCD device during COVID disease, honestly. So I think that they wait 8 days for COVID pathology, of course. About the backup strategy, I think that in according with the surgery, maybe a patch or a surgical attention if the unplugged was not with a good result.
Coli, I think because of this prolonged time of waiting, maybe because of COVID-19, I think, and an 84 female with fragile right ventricular wall, I think because of this waiting, maybe it is the cause behind the perforation. Can you agree with me, or you have any other explanation for that?
Yeah. Also good.
So, Vera, can I ask you? So, first of all, these are amazing cases, but amazing for presentation. Very scary cases, and there are dreaded complications for every lab and every doctor and surgeon. What I want to ask you is that in these cases that you foresee a difficult access, or for example, you have patients that have, particularly the ones that have senile degeneration and probably calcified aorta, and you probably looked at and found that you might struggle getting into the ostia. How fast is it in your hospital to get a perfusionist and a surgeon into the cath lab?
In my hospital, 15 minutes, because we have a few minutes, because we have a 24 hours our surgical and perfusionist.
So should the dreaded be present?
Yes.
So you can put somebody on bypass.
Yes.
Rather in 15 minutes.
Yes, and also we perform this procedure in a hybrid room, and I think that is very important, especially for difficult coronary intervention and also for structural intervention.
This is where I was getting at.
Yes.
So you have a perfusionist in the room?
Yes, in the room. Perfect. They are not on call. They are 24/7 in the hospital and in the room.
Yeah, I think this reflects whatever the panel said too, that the working together before we start the case might prevent complications, which, you know, if it happens, it happens. But the idea is that to not have the near miss, but the near save.
Yeah.
Yes, Saverio, thank you very much for such a fantastic case. For the first case, do you think RV perforation with a temporary pacemaker wire is a classic indication for intervention, whether surgical, which is routine, or endovascular, or there is a role of just follow-up for no intervention? And for the second case, you challenged the classic recommendations of surgical intervention for donning class 3 aorto-ostial dissection. Do you think this indication has to be modified in view of your case and such other cases? Thank you very much.
Yeah. Usually when we have a perforation with a temporary pacemaker of more than 2 centimeters, I think that it's mandatory. Surgical operation is mandatory, because I look electrophysiologists that try to remove the temporary pacemaker. It was a disaster, because right ventricular is not the left ventricular, and as heart surgery we have a brilliant heart surgery, so its spin is not
contracting strongly.
Yeah. So I think that a surgery backup is mandatory, and to remove with the heart surgeon is first choice, of course.
Thank you, Muscoli. I know we are beyond of time. Sorry, we apologize for that, but we cannot end this fantastic night, this fantastic bunch of cases without our dear colleague, my dear friend, Professor Julia, who will present the last fantastic case in this fantastic night. Please, Professor Julia.
So thank you so much. First of all, I will be sorry, that's the first slide, quite quick to respect, not to tire anyone, but it has been an interesting discussion and I learned a lot from all of you. I will present two cases on TAVI complications. So we have a 76-year-old male patient, and he's known to have severe aortic stenosis. And because he has a lot of comorbidities, including previous cancer and that he is high risk for open heart surgery, he has been referred for TAVI. So as you can see on the initial transthoracic echo, his mean gradient is 51 millimeters per mercury. There is extensive calcification on the valve and periannular, and also there is an aortic valve area of 0.6 centimeters square. And the area on the pre-procedural CT measures as 660 millimeters squared. So the patient undergoes a TAV. I hope it play. 1 second to play the video. So this is pre-procedural during the TAVI. So, and the patient is having a TAVI with an Edwards-Sapien valve of S3 of 29 millimeters. Post-deployment now, there is an evidence of paravalvular leak, but also, as you can see here, there is a suspected fistula. So we have two problems. And there is the patient develops first-degree AV block, and he goes into left bundle branch block. And then 3 days post-procedure, he is in complete heart block, and he has a pacemaker. Then transthoracic and transesophageal echo demonstrated this aorto-RV fistula, and there was a concern practically of the small paravalvular leak. So the patient was 2 weeks later, they kept the patient, they were observing how he feels, but 2 weeks later, he's been admitted with acute heart failure, and he undergoes right heart catheterization that demonstrate a QPQS of 1.43. Now, we know that the patient had this aorto-RV fistula, and there was a concern whether it's a supraannular tear, and there is also this paravalvular leak. So practically, this is the post-TAVI CT that will help us define the anatomy and what to do with these two problems. We have the paravalvular leak and the fistula. And the authors describe also that they performed 3D printing as a preparation feasibility for transcatheter closure. They identify practically where's the gap that needs to be closed. And here you can see the pathology that they will try now because the patient was high risk for surgery. And they, after an MDT, they decide that they should try first percutaneously and then, of course, with a bailout surgery. We do the same here. Usually we have a meeting and describe how the patient can have a percutaneous approach, and also the surgeons, as we discussed, they're standby and in case something goes wrong. Also, just to mention that in this session, we describe how the surgeons are hand with hand with the imagers and the interventionalists. So the authors describe practically of how they crossed the fistula with this holy wire. Then what they did first is they delivered the VSD closure device with a 7 French saddle sheath, you can see on the right. And then what they first closed the fistula. And the position of the VSD occluder was successful. And this is the TOE post-device deployment that demonstrates complete cessation of the flow across the fistula. However, there is still the color flow across the paravalvular leak that you can see here from the short axis. And usually on the short axis, very important to define anatomically, starting from 12 o'clock and then going around the circumference on how large is the paravalvular leak. Of course, here, as you can see, it's almost 1/4, 1/3 of the circumference of the aortic valve. So it is an important leak that cannot be left like this. So what they did is they crossed the paravalvular leak, the gap, and they delivered actually the first device across the paravalvular leak, and then they had to deliver a second one, and this is the color Doppler after the deployment of two devices across the paravalvular leak closure. So as you can see, I mean, the patient unfortunately has these two devices that they have to come always at the circumference, the one from the other, in order to seal the paravalvular leak, but somehow it has been improved when compared to the previous picture. Now, after the procedure, so the patient had three devices. They tried percutaneously to close two gaps with three devices. And then his pacemaker interrogation demonstrated that the patient did not have any abnormalities, arrhythmias, and he had the life vest that was discontinued, and then he was discharged. And he's now for 23 months follow-up, and he's in New York Heart Association Class 2. He's on aspirin, warfarin, beta blocker, and diuretic. And also the follow-up transthoracic echo demonstrates no further paravalvular leak, and also the VVSD device is well seated with a small leak only. Now, I guess in order to reduce further this small leak, just a comment from my side that usually you have to top up the beta blockers to the maximum, like up to 10 milligrams of bisoprolol. So the patient was well and he's feeling much better. And as a part of TAVI complications, actually, I tried to find a concise paper that you will see a little bit later. However, we have conduction abnormalities. We have described annular rupture, especially when there is extensive calcification close to the mitral valve. And here I have three landmark papers that they review transcatheter aortic implantation, and they describe also procedural complications. We have the vascular access, the every shunt that can happen around the aorta, our annular rupture, and I will show you also another case next with another complication. So this is the referring paper from Jack Case reports. The authors described actually the aorto-right ventricular fistula and the paravalvular leak. So it was one of the first cases that we presented, and with the use of 3D model, I think it makes a great difference to know how to percutaneously close the leaks. Now, the second case, we have a 70-year-old female lady, and from her past medical history, she's obese, she has metabolic syndrome, and she had the PCI 1 year ago due to silent coronary artery disease with preserved ejection fraction. But she's coming with acute shortness of breath, and you can see that she has significant severe aortic regurgitation, and she has a hollow diastolic murmur. Her ejection fraction, though, is 20%, and her LV is dilated because of the massive aortic regurgitation. And it seems that she has a right coronary leaflet prolapse. That's the main cause of her severe aortic regurgitation. So they say that she's of high risk for surgery, and they try practically percutaneous approach. On the preoperative scan, you will see that she had an aortic annulus area 443, and then the interventionalists, they tried for a SAPIEN 3 of 26 millimeters, because you can see how we match the area of the CT with the valve. But the patient, however, a common problem when we have aortic regurgitation and the experience is limited is that there was absolute no calcification. You can see that with the CT scan, no calcification in order to have a landing zone for the valve to sit there. So that makes things quite difficult. And what happened is during the procedure, initially there was loss of capture during the rapid pacing, and the device practically repositioned, and because of the operators were not satisfied with the shape and the position of the valve, and there was low implantation height, as you can see what happened after the ballooning, it was not a stable valve, and then they did post-dilatation with 2 mLs additional volume. The device migrated and it left and it went practically into the LV. So you can see here that the valve went into the LV, like not swimming, but almost inside the prolapsing into the LVOT. And this is a big problem. It's actually the biggest problem that can happen when you're doing TAVI in aortic regurgitation for the valve to move. So what they did is they crossed with a wire, and they managed to grasp the valve, and they repositioned into the LVOT. However, it was partially upside down. It was not positioned well, and then the patient hemodynamically compromised, and the device jumps into the aorta. So we have from the worst to the worst. And so it goes not only to the aorta, but with inverted position. And now it compromises, of course, the flow to the lower body part, as you can understand. And this is a disaster. So the patient gets intubated on inotropic support, hemodynamically unstable, and the operators quickly go and implant actually a 29 millimeter, so oversized valve with or 49% oversized Sapien 3 valve. And then what they do is at the second, meaning a little bit later, they go with a thoracic graft into the existing Sapien 3 that is now in the aorta, and they relieve the obstruction. So this is how they managed to address the two problems. So here it's an important topic, the device migration and embolization when we have native AR, because as I said, there is no calcification for the valve to land, so it's a technical issue. And it is the one of the risk factors that it needs appropriate sizing, especially with the devices. Sometimes TOE intraoperative will help the sizing of the device and also the degree of calcifications. And sometimes it has been suggested to have an oversizing cutoff of 15%. Then the challenging points are also the device dimension, the stroke volume from the AR, pacing failure, and low implantation height. So there are some procedural tips that we need to look after. And of course, to have, as we said, the surgeon standby and available balloon or snare device. Now, there have been a study called the Travel Registry from Kim in 2019, and they examined almost 30,000 TAVR procedures, and they detected an embolization rate of 0.92%. And practically the predictors is the Sapien valve, the first generation valves, and also the bicuspid aortic valve. It is quite significant complication that may induce death. So it's very important practically to pre-plan with good imaging and to try to avoid that. Also, there's a great paper from doctors Binder and Webb on transcatheter heart valve migration and embolization that they describe the causes and how we can avoid that. This was a paper that was published in January as a part of the complications issue. And as a conclusion, just as a conclusion of this lecture, practically here, rather than having the complications of the TAVI, we will conclude on what makes a device and a procedure safe. And you can see that what defines the device success, that we have to wait 30 days to see the early safety and also the clinical efficacy. So we start practically to have other parameters to understand whether a procedure is really successful. So this is to think a little bit more on how we can look after our patients 30 days after the TAVI and to avoid any acute or other complications. Thank you very much for your attention. And as my friend and colleague El Said described, we are waiting for your submissions, of course, to the journal, and really grateful for you being all here. Thank you.
Thank you very much, Julia, for this fantastic case. And I think we will not be able to end this day without this fantastic case you presented and all the information we got from it. Especially we are full of coronary complication. The second session serving to us a structural complication, which I think is fantastic and we need to know. I see Professor Haney wants to comment, or anyone?
I'm just totally fascinated with more proof on how we work together in teams regarding of our basic trainings or our basic subspecialty to preserve one single life. sometimes improvising or using, and as Dr. Pandis described, some people have, which we've seen in Dr. Mascoli's presentation, amazing dexterity, and they come up with things that you can't think are possible. And to think that all those teams work together, we're not even talking here about this is outside evidence medicine, outside everything. This is the fields where nobody has gone before, and somebody is suffering or dying, and people combine their expertise, electrophysiologists, cardiac surgeons, cardiologists, interventional radiologists, and they go in to save a patient. And I think it's extremely important that we collect those cases, that we discuss those cases, that they get published and they get put in the history of medicine in JACC reports and other reputable journals. And I don't want to, I know this has been a long night. I want to tease you about something. In Cairo, my watch has only one handle. We don't have a minute's handle or a second handle. So my watch just have an hour handle. So it's like 12, 1, 2. I don't care what's in between. So we're so sorry about our time management, but we loved this session. Thank you, thank you, thank you. And thank you, Said.
Julia, do you think that the 3D printing came up to the stage now for solving a lot of problems which cannot be solved by the conventional imaging? And please specify to us to what extent it is helpful, in which situation it's much more helpful, the 3D printing.
So I will start, and then also Saverio and Dimos can correct me if I'm wrong. That when we have complex, first of all, we see a lot of 3D printing in congenital abnormalities when we have complex anatomy. For example, here, when we have the two major problems, it was difficult to understand the correct anatomy for the people. You know, sometimes, as Dimos demonstrated, you don't want the catheter to obstruct another lesion and to go and treat a lesion and then to create another problem. So before, maybe it is like a GPS. Practically, you will go with the 3D printing, you will see the model, and then you will know where to guide your catheter in order not to create any more damage. So I think it helps when we have complicated cases, congenital, a lot of problems, like more than one.
Yeah, it is important for please today, yes.
Yeah.
So for this, if I can just add something to this, I don't know if I can add something more than everyone has already contributed, but particularly in structural heart disease and pediatrics, modeling itself, dynamic modeling and 3D printing, of course, it's a guiding angel for every one of us. I'd like to know, where the holes will be probably, so I'll know what to look at. But what I wanted to, I was going to ask Julia about the first case and about my fears of the position and the potential compromise of the coronary ostia, but I'm not going to. And the reason why I'm not going to is because the second case, I have goosebumps. This is I think this is the pivotal example of the requirement of good communication of heart team. I don't understand how this patient, first of all, was deemed inoperable.
Yes, I think, that's a good question, because it depends on which center
in any center. In any center. So this is a 70-year-old woman. Okay, she's well fed, I would say. So am I. She has metabolic syndrome. I'm not going to ask anyone in the room right now what's their HbA1cs right now in the panel. But what I want to ask is isn't there some guidance when it comes to the industry guidelines when it comes to prosthesis deployment? This patient had no frame against which the prosthesis would hold on to. And our own personal experience, particularly with patients that, on the contrary, are not operable from an access point because of massive peripheral arterial disease and calcification. When we do a direct access melody or sapien, replacement on the mitral position. Even if you do have a circumferential mitral annular MAC, sometimes you actually have to take further stitches and to secure the prosthesis onto the annulus, despite the oversizing against the inflow. Now, in that aorta, which is completely pliable,
yeah.
I don't.
Professor Raghi wants to comment.
I want to answer Dr. Pandis Dimos with a little story, an anecdote. Earlier this year, one of my best friend, Adil Banna, a cardiac surgeon who we trained together in the United States, died of stomach cancer. A few years ago, when Egypt was starting, thank you. A few years ago, when Egypt was starting its TAVI program, the hospital he was working in, a very famous private hospital called Dar al-Fuad, was insisting that the surgeon would write that the patient is not suitable for surgery for the patient to get a TAVI. So even if the patient was like 86, you still had to. So he signed that the patient, who was a healthy 82-year-old, was not fit for surgery. Anyway, the guys went in to do the TAVI. They embolized the valve, and the valve fell in the LV, and it was popping all around. The patient got shocked, and they could not retrieve the valve. They called the surgeon who was in hospital, sitting, drinking, and thinking he was doing a dummy standby. He went in on the patient that he had signed was unsuitable for surgery as elective AVR, and operated on him in shock, removing a free-floating
device
and replacing it with an aortic tissue valve. And I was there when this patient was discharged, absolutely perfect. And I said, how are you even going to look at the admin's face after you had signed a piece of paper saying that he was not fit for surgery when he was so elective? So, surgeons are being nice to cardiologists and letting them do a lot of things. And, it is something which I actually have some feeling about, especially with the new prosthetic mitral valves. There's nothing like a good surgical mitral valve repair. I've seen what they look like. And in Egypt, I know people who even do them in rheumatic heart, and rheumatic mitral regurgitation, which is even more complicated. But again, I seriously don't know why surgeons accept. I think it's pressure from cardiology. I don't know. Maybe it's not the right place to discuss it. But you're absolutely right.
Well, regardless, the well-known or respected, intra-institutional logistical problems, having two people talk rather than one is always best, and particularly when these two people are like the esteemed colleagues that are on the panel, where we can trust their opinion and their experience. It doesn't matter if the approach that is planned for is a catheter-based or an open access, as long as there is an honest discussion about what we aimed to do and how we can bail out. I think by definition, we've increased the option and the odds of a better outcome.
I think we have to end up this very fantastic, very wonderful night with a bunch of complication case with the support of cardiac surgeon, of course, but Professor Bandis. We cannot. It might be like Liverpool. You will not walk alone. Yes, the cardiologist will not walk alone, and he should walk with the cardiac surgeon. I will now leave the mic for Professor Ashraf Reda to end up this fantastic night.
Well, I enjoyed a lot these cases and these discussions, and actually I would like to thank Julia for participation in our activities, and I hope I'm eager to see the wave 5, and I hope one of these waves will be about vascular imaging and the plaque assessment and something like that. And actually, special thanks to Professor Pandis and Professor Mascaras, Dr. Khashaba, Dr. Ammar, Dr. Haniraghi, Dr. Salim, Dr. Khalid Tamam. Thank you very much, and see you next wave, inshallah. Thank you.
Thank you all, and please, we will take the smile photo before we leave.
Okay.
Okay. Khaled, ready? 1, 2, 3. Okay. Thank you very much, and see you soon in CaseBox Wave 5. Thank you.
Bye.
Very much.
Good night.
Bye.
Inhibiting PCSK9 with Praluent to reduce LDL-C. Since its discovery in 2003, proprotein convertase of ptyrosin kexin type 9, PCSK9, has been shown to play an important role in targeting LDL receptor for subsequent degradation. Proprotein convertase of ptyrosin kexin type 9, or PCSK9, acts by reducing the amount of LDLR at the cell surface of hepatocytes. PCSK9-mediated degradation of LDLR, a complex of LDL-C, LDLR, and PCSK9, is internalized into hepatocytes, into clathrin-coated pits. After endocytosis, the affinity between the receptor and PCSK9 is much higher than that observed at neutral pH. The PCSK9 C-terminal domain plays a pivotal role in targeting LDLR for subsequent degradation. Molecular interactions within the PCSK9 LDLR complex, thereby enhancing receptor degradation and consequently increasing circulating LDL-C levels among carriers. PCSK9 has become a target for lipid-lowering therapy. Praluent is a monoclonal antibody inhibiting PCSK9 by preventing it from binding to the LDL receptor. With the decreased PCSK9 activity, LDL is able to disassociate from its receptor within the hepatocyte, allowing the LDL receptor to be recycled back to the cell surface, where it can bind more LDL, thus decreasing LDL-C levels. Praluent, which binds to and inhibits PCSK9, became a target for lipid-lowering therapy. Please refer to Praluent insert leaflet.